That's
Thank you,
some
ma'am.
time back, wasn't it, Naren? It was.
Yes,
No,
yes,
but
sir.
we are seeing him face on
We are
now.
in live, ma'am. Ma'am, we are in
Yes.
live.
Oh, we are online. Okay, right. Let's start it off so that we all go for dinner soon. Very good evening to one and all of you, dear friends, for valuing this webinar and being there. And I'm sure it's going to be a remembered webinar because I have the best of you amongst us. So this time it's going to be tips and tricks for fine-tuning Phaco techniques. And we've been conducting monthly Eyeedu webinars and it has been very well received. We are truly lucky to have on panel with us Dr. Jeevan Titiyai. We all know now he's taken the hero role in a different format this time, heading the Agarwal Group of Hospitals at Delhi after a very prestigious stint as a professor of ophthalmology and chief of RP Center. And we all know what a great stalwart and global figure in ophthalmology he is. I'm truly honored to have you with us, Dr. Titiyai. We are happy to have you with us, Dr. Ramurthy, and we all know he is the dynamic chairman of our Eye Foundation Group of Hospitals and the past president of AIOS. Dr. Rohit Om Prakash is getting a bit delayed to join us, but I think he would be there to deliver his talk. We are very happy to have with us Dr. Shrish Kumar, who is a medical superintendent and has been senior consultant, cornea, cataract, and refractive services. He's not just a gem, he's probably the most precious gem of our Eye Foundation group of hospitals and ever there and very supportive to all of us and a great surgeon. And we are truly lucky to have with us Dr. Kiranjit. Now, he's a specialist in cataract and glaucoma services, and we all know he's a brilliant surgeon and an innovator par excellence. Thank you, Dr. Kiranjit, for being with us. We have very supportively, Dr. Prafulla joined it with this last minute information yesterday evening. And I'm truly happy to have him with us on the panel too. He's an additional professor at RP Center, consultant cataract, cornea, and refractive services, a young, very dynamic professional, academician, and also the awesome secretary of DOS. And I look forward to hearing what he's going to tell us as the first speaker. We are very lucky, and I'm truly lucky to have being my co-moderator, Dr. Narsi, who's actually a backbone of our Eye Foundation group of hospitals. She's a senior consultant cataract and intraocular lens services. Again, a very dynamic surgical trainer and an academician. And she is going to be giving me a hand to ensure this meeting goes most informatively. So without wasting time, let's go on to our first speaker, Dr. Prafulla, who's going to be talking on CCI and overlooked surgical step, how to perceive and manage better with eye OCT. So on to you, Dr. Prafulla. And Dr. Kiranjit, we need to see you.
So there I am.
Good evening, everyone. So I'll be speaking on this particular topic. And as ma'am said, initially I was not a part of this program, but Dr. Namta, I think because of some commitments, she couldn't join. So I'll be delivering her lecture only. So the topic is wound construction or CCI, as ma'am suggested. So why this is important? Okay, so to this part. Okay, so why wound construction is important in phacoemulsification? Because all of us now we understand that if you want to have a good phacoemulsification experience during surgery, you have to maintain the fluid balance properly, and that depends on a lot of factor. But the most important factor to begin with is wound construction. Then second, any further surgical steps like CCA, CCC, hydro, all this depend on your first step, that is wound construction. And third, nowadays the patient's demand has gone up so much that even you put a suture, they are like, why did you put a suture? It should have been a sutureless surgery. So if your wound goes wrong and it doesn't seal, you may have to put a suture, which may be demoralizing for the patient. And yes, one often ignored fact, we see a lot of tunnel infection or post-op endophthalmitis cases referred to us where the wound is still leaking. So that is an important part. If your wound leaks continuously during the post-op stage, you may land up in complications like infection. And Post-op outcome, for example, if you are putting in toric intraocular lens or toric multifocal IOL, the post-op rotation also depends on how tightly you have sealed the wound. So all this depends on how good your wound construction is. And lastly, UCVA, how this is important now, people are going from the cataract to refractive cataract surgery. So patient 166 and N6 on next day. As if your wound is not proper and there is healing problem is there, and the SIA or surgical induced astigmatism is high, then again the patient will not be satisfied with the surgery. So that's how important the wound construction become for nowadays. Now, site of often most of us prefer temporal surgery because most of the time in elderly patient we have this against the rule astigmatism, and temporal wound is quite far from the central visual axis, so that's of the best for most of us. But however, in case patients where the 90-degree axis is stiff and there is an astigmatism more than 1.5 diopter, you can consider that. But again, for beginners also, they prefer this superior because they have some support to keep their hand. But or otherwise, temporal incisions are preferred. Size of the incision, well, this is the study that I went through, and they have classified that any wound less than 1.75 is you can label this as short length incision, or anything which is more than one, you can label long length incision. And the second aspect is width. Width, it depends on the size of phaco probe that you are using. If you are using a 2.75, make it 2.75 incision. If you are using a 2.2, make it 2.2 incision. Length, as I said, length is the how much long the tunnel is into the cornea. Shorter length incision, they are easy to make, but the problem is they may leak. It's difficult to achieve a self-sealing incision. Long length, they easily self-sealing, but the problem is at times you must have noticed when you are training your resident, the phaco probe, they find it little difficult to go in. They struggle at the wound. So that problem may be there if the incision length is longer. And at times, if you go too much near to the visual axis, again that will induce a lot of SI and post-op dissatisfaction by the patient. So these are the different type of incision we all know: uniplanar, multiplanar, or biplanar. So the tussle is between how stable the wound is and how difficult to handle the wound. Multiplanar are good because they are self-sealing, they prevents post-op leak, post-op infection, everything is reduced. However, at times you may find it difficult to manipulate your instrument, and the incidence of DMD may be theoretically high if you are doing a 3 or 4 planar incision. Now, these are the few videos from Dr. Namta which I will be showing you. So this is a case where you can see, if you see properly, the surgeon is holding the conjunctiva here, right? And there was an irregular wound. So whenever there is some problem in wound construction, there may be problem with the patient, or there may be problem with the instrument, or maybe the problem lies with the surgeon itself. So if the patient is moving, you are doing under topical anesthesia, then that's a problem. You have to stabilize.
Doctor, 1 minute more.
You have to, shall I continue?
You have 1 minute more. Actually, it's a 4-minute talk. Yeah.
So these are the problem that you may have with wound construction. So to avoid that, what you have to do is you have to uh, support the glove first, and second, make your patient comfortable, and third, use sharp instrument. Don't use blunt instrument. Then second is iris prolapse. If you construct a proper poorly constructed wound, then there can be iris prolapse, as you can see in this video. And the main problem lies with, again, the patient factor. Patient is uncooperative, patient is squeezing too much, IOP is high. So stabilize that. You can use intracameral anesthesia if the patient is under topical and uncooperative, or it may be with the surgeon. Your wound is large or extending, or you are putting BSS hydrating the wound, but the fluid is going into antechamber, or it might have overfilled with viscoelastics. So all these factors you have to avoid. And you can see in this video, I think, yeah, the wound is, there is iris prolapse and somebody is doing bimanual. Ideally, that should be avoided. Whenever such situation is there, you should always suture, put the iris back, and then do your rest of the procedure by bimanual if irrigation aspiration is still needed to be done. So these are the various causes which I have already enumerated. Iris prolapse management, as I have already said, if the iris prolapse is from the main port, it's better to suture it If that is not possible, inject some viscoelastic near that, and that makes your life easier. If it's for the side port, again, you can create a new side port and complete your procedure. DMD, if you construct the wound poorly, then there is highly likely that you may land up in DMD. Most of the DMD are port near your wound only. You can see here, and that doesn't create any problem. At the end of the procedure, inject some air, then burp it through the main port. Usually, it gets reattached. However, if you are not careful enough, then in those cases, it may extend further. So for that, you have to be extra cautious. And there are few tricks, as you can see in this video. The DMD was enlarged while doing IA. You can see this is a microscope integrated OCT, and the surgeon is going with the fluid full on. So if you do that, the DMD may enlarge. So whenever there is a DMD, what you can do is either close it and start with a new wound, or minimize your instrument entry. Don't go through that port again and again. And wound assisted IL injection should be avoided in these cases. And at the end of the procedure, you can suture the wound and achieve an airtight chamber, and then collapse the air bubble so that the DM gets attached. Then last part, I'll speak about this femtocataract. At times, the problem with the incision, you have created the incision, but you fail to find it. So there are different techniques described for that. One easy technique is we can put a drop of trypan blue that will give you the outer lip of the incision that you have created. Then you can try to go in again. If that doesn't work, anyway, you can create using a 2.2 or 2.8 keratome, and that doesn't affect that much the outcome of the surgery. So I think I'll conclude here. I'm running short of time. So thank you so much. And this was a talk by Dr. Namita Sharma, which I took because she was not here. But I am currently the secretary of DOS, and I'll use this as an opportunity to invite you all to our annual DOS conference, which we are going to do from 13 to 15 June at Bharat Mandapam. And this is our Diamond Jubilee celebration. So please join us. Thank you.
Thank you, Prafulla. Thanks for a lovely talk, and of course, the dynamic presence indoors. Do stay on till you can. And I would start with Dr. Titial. Dr. Titial, how do you feel about IOCT giving you that extra information? Like, do you feel that uniplanar or biplanar or triplanar, which would be the way to go as far as the wound architecture and apposition is concerned? And of course,
I
the
think,
other thing.
first of all, let me make clear, IOCT doesn't, guide you to make incisions. That only, depicts what has happened after you made an incision. Or it can also help you in picking up the complications happening, especially the descending membrane detachment, which happens in these cases. Configuration-wise, if you look at triplanar incisions, definitely better, physiologically also, but that can be achieved only by femtosecond laser plannings. Manual incisions normally either biplanar or a uniplanar incisions. Very difficult to create triplanar, which will be a misnomer sometimes, But yes, important thing is it's not the biplanar or triplanar. It has to be the proper incision to suit your, Phaco surgery during, that means the incision and your instrument, your tip and the sleeve should match with the type of incision we have created without causing any complication related to the wound area, that is heating or a burning or a damaging, leaking. Other important thing is, it's not only the initial incision which is important, after your Phaco, how much distortion it has occurred. Because after Phaco, the distortion, if it happens because of heat, then the collagen fibers will take long time to recover back, and that may be cause for an induced astigmatism. After IA, after IOL implantation, after hydration, wound has to be checked properly. I think most of the points were well covered by Praful. As far as we are concerned, whatever picturization we have done to IOCT, we looked into the proximal part of the incision. If that is clean, like a slit incisions, it doesn't cause significant descending membrane detachment at the wound site. If it's a ragged incision, which normally happens with a dull or a blunt blades, then there are chances of descending membrane detachment happening during the procedure. And in especially difficult cases, it can enlarge also. Otherwise, IOCT assay doesn't help in making incision, but it can pick up various other factors.
Kamal, can you take the second question?
I just wanted to know from the panel that we have understood that the centroid SAE is 0.1. Does it make sense to change your incision based on the astigmatism? Like we all go with the temporal clear corneal incision. So do you plan superior for with the rule, or what is your
Can you
take on?
direct the question? I think let's Ramurthy take the question. Kamal, we'll have to direct the question to one particular
Yeah.
person. So we don't waste time. Yeah.
Okay.
Yes, Dr. Murthy.
No, I sort of agree with Dr. Tamil. Definitely, nowadays, earlier we used to do it on the steep axis, but nowadays, because the sub 2.4 millimeter temporal clear corneal incision has just a 0.1 diopter of centroid value, SIA. Nowadays, irrespective of the amount of astigmatism that we are dealing with, it's always a temporal clear corneal incision that we make. And essentially, if there's significant astigmatism, especially against the rule, we more often go for a toric intraocular lens. The only place I use an incision to address astigmatism is maybe when I'm using a phakic intraocular lens, for which I make a 3 millimeter incision. Many of these youngsters have a with the rule astigmatism, that is 90 degrees axis steeper. There, when I make a 3 millimeter incision at the 90 degree axis, up to about 0.5 diopters or 0.6 diopters gets corrected. So low degrees of withdrawal astigmatism, I use it. As far as both the opposite clear corneal incision as well as incision on axis, given, because I do agree with the concept that the centroid value of incision is just about 0.1 diopter, especially if it's well made and it's less than 2.4 millimeter in size.
Dr. Kiranjit, do you feel that what could be the modern reasons to get the wound burn when now our Phaco machines are so optimally designed, whether that's for the efficiency and the way we set our parameters? So can you tell us why we could really get a wound burn in the present era? What practical problem comes up? We can't hear you.
I think he needs to unmute himself first.
Yeah. So if you have a very hard cataract and you have a long tunnel and you're taking a long time to sculpt the nucleus, then you can have a corneal burn, a longer incision. But what I do is I make a slightly scleral incision and not a long one in cases of hard cataract, so that that incision, there should be little bit of ooze in that area, so that healing is proper, and there are no chances of infection and no chances of wound burn. So if you have a hard cataract, you should opt for a small incision. The length of the tunnel should not be much. So that is my way of thinking.
Shail, I'm going to ask you here. Sometimes, the viscoelastic comes and blocks the aspiration ports. So, and that could also generate a wound burn. So how would you give an idea how to sort this out?
I think the very important question is therefore always keep your ears on. So if you hear a ting sound, that means don't go ahead with foot position 3. Because if you keep continuously hearing a ting sound, that means there's an occlusion at the phaco tip. And if you're then in foot position 3, that means there's no flow that is coming in and only ultrasound that is going in. And that's when you can get a wound burn with whatever the machine, whatever the technology that you may be having. So when you constantly hear ting, 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 that means there's too much of occlusion. Maybe raise up the vacuum, raise up the flow rate, take out that excessive viscoelastic, or maybe just come out. Maybe now the tubings have got blocked because of the viscoelastic. Reprime them, reflush them, and only then go ahead.
I think that there could have been more questions on DMD, but Velmugan, is our 5 minutes up? Discussion time?
Yes, ma'am.
Yeah. So that I think just since Dr. Tityal, Shrish, I'll ask you this. Can you tell us one simple tip? You have already created a DMD. Can you just give a tip as to how we could manage it so that it doesn't get enlarged for a beginner surgeon?
Yeah, you should, yeah, that's a good question. Like you should know where exactly is the DMD is, whether it is along the incision and whether it is originating. The cut end of the DM has to be identified first. Then you can plan your surgery. If at all the cut end is at the wound, then you know that by the fluid it can enlarge, so we have to take care of this part. And while entering into the anterior chamber, we should be very careful, inject visco in such a way that it is flattened over the under surface of the cornea, and then enter without fluid, and then in the anterior chamber go far away from the site of damage, that is the DM tear, and complete your phacoemulsification. You should be further away from the area of tear and complete. If it is a very large tear, it's a very large tear that is extending from limbus to limbus, then of course you should close the wound, put a big air bubble or C3F8, and then you do a surgery at a later date.
Also, if you're going to go through, if it's a small DMD, go through the same incision. You should go with your infusion off. So that is the
Yeah.
most important thing.
Exactly.
We shall now go on to our second speaker, Dr. Harshul. Dr. Arunmoy Varman, you could go in as our third speaker. He requested us, so we have to be making this change. Otherwise, it's going to be going along in the same sequence as was given in the flyer. So Dr. Harshul is a chief eye surgeon at Rawat Eye Hospital, Rajasthan, and is besides the fact that we know his surgical prowess is par excellence, and he makes probably one of the best videos in our country. But what is also important is he's the chairman scientific committee of the very awe-inspiring Jaipur Ophthalmic Society, and we look forward to seeing how well it's going to flourish under his tenure. So on to you. He is going to be talking on extending and extended rexes, how best we would handle. 4 minutes.
Thank you so
the time frame, please. Yes.
right. Thank you so much, ma'am, for giving me this wonderful opportunity. Can I get permission to share my screen?
Yes, sure.
Yes, sir. Already permitted. It's not there.
Velmurugan has to share,
So
right?
can you share, sir? No, I can't. That share, I can't, Sir, you just click the just a minute, just a minute. Yes. Huh?
You have opened your presentation beforehand, no? Do you want to go as a third speaker? Velmurugan can. You've done so many webinars, I'm sure there's.
Okay. Yeah.
Oh, you want me to start?
Yeah. Harshul, you sort your issue out.
Can I start?
Yeah. Dr. Varman, please go ahead. Yeah, I'll
Okay.
just check.
Yeah, we have just a minute. We have Dr. Arunmoy Varman to take on his topic on horizontal chop versus vertical chop, the critical tips, and his duration of talk is 6 minutes. But more importantly, Dr. Arunmoy Varman is one amazing cataract and refractive surgeon, medical director at the Uma Eye Clinic, and presently is the president of our Tamil Nadu Ophthalmic Society. And let's hear from him about horizontal versus vertical chop.
Thank you, Chitra. It's a pleasure to be here. Thank you for the introduction. So let's say, what is phaco chop? Phaco chop, can you hear me?
Yes, we can hear you.
Phaco chop is where you hold the cataract or at the nucleus with vacuum, hold it with the phaco tip, enter in, lollipop it, then use the chopper to break up the cataract into smaller pieces. That gives you the ability to aspirate out the cataract efficiently with lesser energy. There are two ways that you can do this. You have this so-called horizontal chop and a so-called vertical chop. I rather call it as a central chop, the vertical chop as a central chop, and the horizontal as a peripheral chop. That actually is more descriptive than saying horizontal vertical, but we'll stick with whatever is being used. In the horizontal chop, the nucleus is impaled in the center, held with vacuum. A blunt chopper is taken horizontally under the rexus, and then it's at the point where you think you've reached the equator, You turn the chopper vertically, then you break up the nucleus by drawing the chopper towards the phaco tip and separate. That means you start the chop at the periphery and proceed to the center and take it out, divide it towards that. In vertical chop, the nucleus is impaled the same way in the center, but you use a longer, sharper chopper and you enter vertically into the substance of the nucleus within the rhexis margin. You don't go beyond the rhexis margin. And then you draw these two instruments together and separate. So you get a central chop where you break up the center perfectly. So this is where the two different chops come in. So what is the advantage and disadvantage? The horizontal chop, the advantage is basically that it is very predictable. It's easy to teach, and every time you do it, you're pretty much sure it will work perfectly. Disadvantage from my point of view, it's partly a blind procedure. When you go under the rhexis and you go towards the equator, you're just imagining where the equator is and turning around. That's one. But it becomes far more blind when it's a small pupil. Or you start off with a moderate pupil, done the rhexis. As you do the surgery, the pupil comes down. You really can't see the edge of the rhexis, and then you'll have to go under it by touch and feel, as I say, and that also makes it a totally blind procedure. Third, it is very difficult to do this where there is no cortex and epinuclear cushion. Absolutely large brown nucleus, trying to get under that every time perfectly is a bit of an issue. So these are the difficulties horizontal chop. In the vertical chop, advantages, it's under perfect visualization. It is safe in small pupils also, and also in cases where the cortex epinucleus is almost absent. So it's everything under vision. Disadvantage is that every time you do the chop, a vertical chop, it can break a little differently. You can't really predict how the nucleus is going to split at that particular time. And it's also a little more difficult to teach and master compared to the horizontal chop. So let's look at the videos. I don't do horizontal chop at all. This I picked up from the net. So this is where you clear up. You get ready there. Take a blunt chopper, which is long. Go under the rhexis. You can see that. Hold the nucleus at the very edge. Then you can impale at this point by holding it and then draw the chopper forward. So you find whether it's a hard cataract or soft cataract, it's a predictable chop. You're starting the chop in the periphery and then you're coming to the center. You're very much sure that you will get a perfect chop every time. But is that possible to do this kind of a surgery in every single case? So let's take this kind of an issue where it's a very, very hypermature cataract. I'll just speed it up a bit for time. The lens, the capsule was fibrosed. So we had to use, we couldn't hold it with a microrhexis forceps. And we have to do, actually even cut at one point to start with getting the rhexis a little better. It keeps coming on. At this point, you'll find there's a fibrosis, and any further pull is going to pull on the whole zonules.
Doctor, time is over.
You said 6 minutes. How 6
Yes,
minutes?
yes.
Okay. 6 minutes definitely is not over. So we use a scissor to cut. Now we'll speed this up. I'll show you this vertical chop. Now I'm using a sharp chopper, cleaned it up. Make a small punch right at the top. Hold, enter vertically right there within the rhexis and break. So you're staying absolutely within the center. So you know where you are, what you're doing, and everything is under visualization, the second chop. So you're staying well within the rhexis and you get a very good chop. But the difficulty here is vertically impaling with a sharp chopper and using it to break it up. So let me speed this up also and then go to one more video and I'll end my talk. We'll go to the next one. So this is showing how a vertical chop is done. How would you handle this kind of a situation? You have a small pupil, hard cataract. So I do a stretch. Do a rhexis. Now, in this kind of a situation, you can't see the edge of the rhexis. Trying to go under where you have hardly any nucleus, epinucleus or cortex is very difficult. So you're forced to stay in the center and you do a perfect job. It is not at all difficult provided you follow the lollipopping technique. Lollipop, enter vertically, and then separate. With this, what appears to be a small pupil with all the difficulties, hard cataract, is done quite easily, very efficiently. So coming back to the pros and cons. Horizontal chop is more easy to teach, is more predictable, is something that somebody can easily follow. Difficulties, you'll have to get under the rexus every time. If the rexus is not visible, or you make a mistake, or the pupil is small, you get into trouble. If the epinucleus or cortex is not there, it becomes very difficult. Vis-a-vis, the vertical chop is far more efficient, a little more difficult to master or teach, but once you've got it, it's perfectly easy to do and you'll get excellent results. Thank you.
Thank you very much. That was a lovely presentation, Dr. Arun. Dr. Tithial, I would want to ask you, what would you feel is the best orientation of the bevel of the phaco tip?
I think, it depends which type of tip you're using, angulation, because most of us are using nowadays, Kelvin modified tips. The bevel should be, should be facing towards your side so that you can have a better feel and hold. And the depth is also very important. Whatever bevel you use, the depth is important. That's why a little trench sometimes does help you. Or you have to go very hard onto a central part of the nucleus to hold. What Dr. Arul was talking about is very clear, like, whichever tip you use, it may be 30 degree, 45 degree, because 30 degree is the one which most people are comfortable with. If you have a good hold, you can do any type of chop. I think the hold is very important. And sometimes you have to have a multi-hold also. You have a primary chop you're doing, it may not be complete, so you can go deeper and deeper, hold it properly. So I think 30 degree is the best one. And if you are using an ozil system, better to have a visible tip so that you can see a proper placement into the depth also.
Tamil, can you ask the second question?
Yeah, Dr. Kiranjit sir, do you change your settings when you're shifting from a 2.2 millimeter incision to 2.8? Sometimes the indigenous eye will requires a 2.8 millimeter incision. Do you shift your phaco parameters, change it?
No, I never go through a 2.2 millimeter NCN. I always go through a 2.8 millimeters NCN. And as far as this chopping is concerned, actually we are trying to teach the young generation. The important thing is we have to keep our endothelium safe, because I belong to a old thought school. So what I don't indulge in too much of chopping, whether it's a vertical chop or a horizontal. I do this divide and conquer. By divide and conquer, you actually decrease the size of the segment you are going to pull out through the rexes, and less chances of endothelial damage. So I think that divide and conquer is still very good as far as hard cataracts are concerned.
Yes. Since all of you all are there, I thought I'll get Naren also involved. Naren, do you believe that hydrodelineation makes your horizontal chop better? That is, assuming that you do horizontal chop too.
Yeah, thank you, ma'am. So I think it really depends. I mean, I personally do not do hydrodelineation unless it is a posterior polar cataract compromised posterior capsule. Most of my chops are vertical, but personally, I don't have much of experience in horizontal chops, but I've done in my initial training time. But I would say is if I mean the whole purpose is you need to have a nice clear cut chops with the posterior pole also, I mean posterior plate also being separated. I think most of the surgeons do without hydrodelineation. But what happens in very soft cataracts, some people do use a technique where they hydrodelinate, pop up the central nucleus part and then remove the epinucleus. That's also a wonderful technique. Yes.
No, actually, hydrodelineation does help because in soft cataracts, but the adult soft cataracts, not the very soft cataracts, when you hydrodelinate, you are actually making an outline of the endonucleus. and you can very easily chop it into pieces and get it out. Just one simple, easy way to do it. The last question before we go on, Ramurthy, would you have a particular technique of chopping for a particular case, or like majority seem to be all for vertical chop only? Would you change your technique for a particular case?
I use a fairly standardized technique in the sense that, like Dr. Tityal said, I always make a small subincisional groove from the rexus margin up to almost a little short of the center. Where it's a soft cataract or a hard cataract, I feel that it gives enough purchase onto the meat of the nucleus. Very often, sometimes in a very soft cataracts, it's really not necessary. You can remove it by just carousel. I think most of us don't do the classical vertical or horizontal chop. It's more a combination, like vertical chop. The classical method was supposed to be just beyond the phaco tip. You worry the phaco needle and move them in the opposite direction to chop. Well, the other one, you go all the way, the horizontal chop, you go all the way up to the equator. But basically, once I get a purchase onto the nucleus, I just go beyond the rexus margin and then worry the tip of the chopper into the material of the nucleus. The tip may vary depending upon the hardness of the nucleus, then draw them together. So I think it's a combination technique, and I don't know whether others will agree that most of us have gone away from the classical vertical and horizontal chop that was described, and it's more a mix of both that we use, and it seems to work well in most of our hands.
Thank you. Yes, Arjun?
Yeah, so I totally agree what Dr. Ramurthy has said, but one like situation where you have to do horizontal chop, otherwise you're not able to chop is a Morgangian cataract, where you don't have any support there. It's a totally mobile nucleus. So in that case, I always bury tip in the center and get your chopper from the equator of the lens to divide it into smaller pieces.
Yes.
Otherwise, I agree that it's a mix of, it's not a classical vertical or horizontal we do. It's a mix of chopping technique which we use.
So
That's
Harshul,
that's the cracking the nucleus, not the chopping. What Harshul is talking about is basically cracking the nucleus from periphery, and it's possible in these type of cases.
Yeah, hypermature cataracts.
Yeah.
In those cases, the nucleus actually prolapses into the anterior chamber. It's a small hard nut, and you have to. Yes.
Yes, Harshul, can you open your presentation?
Yeah, ma'am. Okay. Can you see my screen, ma'am, now?
No, we see Zoom, the browser.
Not yet, not yet.
I think something is.
If you want, you can share your presentation with Vel Murugan. If you can, I'll call you back again and then present, because we definitely want. Dr. Rishi has not joined in yet. Shall we go on? Shall or Ramurthy? Dr. Ramurthy, would you? I think yours come before that. No.
I mean, I don't mind.
I can go to press if you want.
Yes, sure.
Yeah, sure.
Yeah, presentation. Yes, sure.
Yeah,
and it's a pride to have Dr. Shail with us. He's a senior consultant at Raghudeep Eye Hospital, Ahmedabad, and an amazing surgeon and extremely academic. And I think every word he talks will have an information and a pearl for us. And it's a pride to have you amidst us, Shail. And he's going to be talking on conquering soft cataracts. So let's hear.
Thank you, ma'am. So after all the talks on chopping, this should be a little change. We do receive research grant support from Alcon Laboratory. So these are the kind of cataracts that we are looking at. So they are not in their 20s and 30s. They are in their late 40s, 50s, or even 60s, where the nucleus is not very dense. It's practically clear. But they have these either posterior cortical cataracts or posterior subcapsular cataracts with not much of a dense nucleus. And although the patient is more visually disturbed by these cataracts than the nuclear cataracts, quite often these are the cataracts that cause more difficulty to us intraoperatively than the actual very dense cataracts. So we really need a surgical strategy that is safe, effective, and predictable. The biggest problem in soft cataract is In some cataracts, something works. In some cataracts, something else works. So normally what you start off with is typically to doing a smallish capsulorhexis in routine situations. In a soft cataract, maybe if at all you may end up doing a slightly, you might want to end up doing a slightly larger than a normal rhexis, so that in case you find difficulty or a bowl creation occurs, there's more easier chance of prolapsing the nucleus out. Normally, this is what I would do alone. That is only hydrodissection, and hydrodelineation is something which I don't routinely do in any of the normal cataracts. But sometimes in very soft cataracts, I do believe doing a hydrodelineation may help to create some at least central zone of denser nucleus, the typical golden ring sign that we see, which will allow us to make use of the very small
Arul, you have to mute yourself. Arul, you have to mute yourself.
So quite often,
Arul, can you mute yourself? Yeah.
so sometimes these very soft cataracts, it's only this very small central nucleus which is actually dense and which can have a hold. And therefore, in a normal case, I would always do a trench first, like Dr. Ramamurthy said. But in some of these cases where I know young myopes, where only a very small nucleus hold might be there, I go for a direct chop, so that whatever that little bulk of central hardness of that nucleus is there, I can, occlude that and at least create 2 or 3 chops, so that even if I then fail to create further chops, at least I have 2, 3 fragments which I can handle. But like we've all know, chopping doesn't work in many of these cases. Like in this case, it's a fairly myopic eye. I'm struggling. I've done sculpting. It doesn't divide. Then I'm trying to again sculpt to make it thinner so that at least I can laterally separate and divide. But sometimes none of these techniques tend to work predictably or effectively because you don't get a hold. And then you end up typically in a bowl kind of a situation where you neither have left anything to chop for yourself, you've neither left anything to sculpt and divide for yourself. And that is something which does occur, particularly when all of us are, very steadfast chop surgeons. We want to chop everything. So in a very soft cataract, I think the 4-quadrant technique or the divide and conquer is something I go back to, because that allows us to thin out the central nucleus in all 4 quadrants, so that even if it doesn't physically divide, it will still then prolapse out, tumble out and come out. Otherwise, it won't even tumble out. The fear in sculpting in a very soft cataract is that you may go through and through the nucleus and you may end up catching the capsule. And therefore, use a very, very low flow rate of 14 to 16 cc per minute and a very low ultrasound power of 20 to 30%. So keep your setting only very low so that even if you go full pedal, you are not going to end up eating up the nucleus very high, and a low bottle height. So this is what I mean. I've set an oscil of only 20% in this case because it's a softish cataract. And I do a traditional normal sculpt, and then I go even below the rhexis. You have to be conscious about the depth, but I go even below the rhexis to create a long 4 quadrants so that I'm creating enough thinning all around. And because my flow rate is very low, I'm not very worried that even if I go through and through in some part, I'm very unlikely to catch the posterior capsule. So go ahead, keep thinning more in the center than in the periphery. So center and mid periphery is something that you want to make sure is very thin, so that even if it doesn't kind of, divide completely, if it's not hard enough to divide, you'll at least be able to, tumble them out because they've now become very thin at the very base. During fragment removal, again, we want to be careful that we don't use a very high power, because if you end up trying to use a lot of high power, you won't get a hold on it. So if you have been able to divide like this in a 4 quadrant, what you can then do is, again, you may have a slightly higher power than what you did for your division, but not more than 30 or so, because you hardly ever need anything more than that. And a vacuum, not very high, because I don't want to, go through and through again through a soft nucleus. So I keep a vacuum of around 300 to 350 and a flow rate of 20 to 25 cc per minute. And the other thing that helps is keep everything in the center so that the iris also doesn't misbehave. A fluid doesn't keep going back, and there's no iris prolapse, which you saw in that case previously where I struggled to chop. So keeping your parameters low and doing a 4-quadrant technique, I think, is my standard to go. When I see in the OR list that this is a grade 1 or a grade 2 cataract, I don't even attempt a chop in some of these cases, and keep a very moderate vacuum and a moderate flow rate. And if you have access to flags, I think these are the cases where we like to do the cylindrical lens division pattern, which means this will act as multiple hydro delineations, so as to say. And because these are now very soft cataracts and multiple hydro delineations have been done, therefore it's easier to kind of even aspirate them en masse
Doctor, time
in,
up.
in these cases. So these are some of the things that I find very useful as far as soft cataract emulsification goes. Modify your approach. Don't stick to the same old chopping. Be flexible. Go back to 4-quadrant. 4-quadrant will work in anything where nothing works. So 4-quadrant should always be mastered, and that's something that's your go back to technique. And use low parameters, particularly in soft cataracts, so that you don't have the fear of going through and catching the posterior capsule. Thank you so much for the patient listening.
Wonderful tips, Shail, and definitely there is all of us will keep these points very much in our mind. Going back to Dr. Titiyal, no, Shrish, what would you do, Shrish, if you have been operating on a soft cataract and then there is this bowel formation which Shail was talking about? How would you handle it?
Yeah, Dr. Shail has mentioned all the techniques of managing soft cataracts, and he has even mentioned above the age of 40, you have some formed nucleus, and below 30 years of age, there will be hardly any nucleus. So in such cases, just aspiration, irrigation aspiration or phaco aspiration itself is sufficient. But if the patient's age is around 40, 45, and there will be some formed nucleus in the center, and you can do either a hydro delamination or even a mechanical delamination without hydro procedure, and you can delineate the nucleus and you can crack the nucleus right in the center. You will have some formed nucleus, and you can crack the nucleus and do whatever the technique you are comfortable with. And then the epinuclear bowl can be aspirated easily, either with the irrigation and aspiration. And this works very well.
And as far as refractive lens exchange is concerned, Dr. Ramuti, what would be your technique?
I mean, what Shell said was all relevant. Usually, we are doing refractive lens exchange only for patients in above the 50, who are in their 50s, and usually hyperopic patients. And these, as was mentioned both by Shrish and Shell, they will have some form nucleus. So I go back to my normal technique, that is make a small trench, try to bury the nucleus into the tip into the substance of the nucleus, and create a chop. Just in case I'm not getting it hold and it's too soft, all I do is to extend the trench and make it a full length trench from 6 to 12 o'clock. Then going with 2 Sinskey hooks, it's just my own modified way, and crack the nucleus into 2 halves. So whether it's a hard nucleus or a soft nucleus, I find that this stop and chops works well. And once you have broken the backbone of the nucleus, then you are able to take it out quite adequately. One point I want to emphasize is that all of us talk about adequate size rexes, 5.5 millimeter rexes in hard cataracts. But I think it's equally important in soft cataracts also, especially the very soft cataracts where if you have a 5 millimeter or 5.25 millimeter rexes and do a good hydrodissection, the entire lens material seems to pop out as a pulp, or has this salute sign where it stands up. In that case, you just go ahead with your quadrant removal settings and aspirate the entire nucleus using hardly any phaco power.
Tamal, you have any question? Can you take? And we go on to our next
Yes,
talk.
ma'am.
Arshul, I think we're ready now.
My question is to Dr. Shail only. I also never chop, but I try to do a stop and chop. When you do a divide and conquer, do you think that the surface area of your wall of the trench becomes very small and is difficult to crack, divide and conquer in soft cataracts?
Not really. I think like any four quadrant technique, I mean, we don't want to make a very wide trench, of course. I usually don't widen the trench very much. I just use the one width of the Phaco probe, which I find is sufficient enough to put both my instruments in the wall and divide. So I don't really make a very, very wide trench. I don't think that's very necessary.
That's fine, sir.
Yeah, thank you. So I think we'll have Harshul talk, and after Harshul, we'll have Ramurthy giving his talk so that you have some idea of the sequence, because some of these doctors have not yet joined in. Tamil, could you
Yeah.
make a call to some of our speakers in the interim period to join in?
Sure, ma'am.
Yeah. So yes, Harshul.
Thank you. Can you see my video, ma'am?
Yes, yes, yes. Harshul.
Okay. Thank you so much for giving me this opportunity, and I'm very sorry for some technical glitch there. So I'll be talking about how to rescue the extending rhexis and what to do if it is extended. So this is the case where its rhexis is, I'm making a cystitome and it's going routinely. But as I reach in this place, if you see the direction of the rhexis is going outwards now. So at this point, we need to stop there and we need to go and put some OVD in front of the leading edge. And then we need to pull this rhexis in the center. If you look at the direction of the pull of the rhexis forceps, it's towards center. And the rhexis is coming back on the right track. So this is a maneuver which every young surgeon or any surgeon should know and should use in the case where your rhexis is trying to go outwards. Another case where it's a mid-dilated pupil, rhexis again is going outwards and it's going behind the iris margin. I'm trying to get the rhexis on the right track, but it's sliding downwards. So now here I can't see the leading edge. So whenever, if you can't see the leading edge, don't go and do blindly. Because of the site of the rhexis where it is extending, I'm not able to use my Kugelens hook or any ball tip dialer to retract the iris because this is the left side. So what I'm doing here is making one side port incision and using iris hook there and going in front of the leading edge so that I don't tear the leading edge, again putting OVD there. And once you place the iris hook there, you can now visualize where the leading edge of the rhexis is. So this little time which you are spending here, it's worth it. You can save the rhexis from this place. So here now I can see the leading edge here, and again pulling it toward the center and getting it on the right path. So you can see the rhexis is coming on the right path here again. So there's a little trick which you can use if it's a mid-dilated pupil and you're not able to visualize the rhexis margin. Another case where I'm using a cystitome here, reaching to the subincisional area, I go ahead and put OVD there. And using a rhexis forceps here, but look at the direction of the rhexis. Now it's going outwards. So at this stage, you need to stop. Again, see in slow motion is now that. Now again, you need to stop here, put some OVD. And go from another side port so that you can grasp the leading edge of the capsule rhexis nicely and get it on the right track. So you need to have these rhexis forceps, micro forceps, which goes through side port incision. So again, just pulling it in the center, get the rhexis on the right track. So I'm just pulling it towards the center. Now, this is an intumescent cataract. We all know that they have a strong tendency that rhexis may go outwards. So you saw that jerky movement of this happens sometimes in topical anesthesia, that patient suddenly moves his eyes, and see, I was trying to debulk the capsular bag, and in that process, suddenly there was a jerk, and I was trying to debulk the capsular bag, and because of this movement, the rexis has now this has irregular tears like this. So here you should always go and give a relaxing cut there. And once you give this cut, try to incorporate these irregular curved tear into the rexis margin. So go ahead and put high molecular weight OVD, go from side port, and again I'm enlarging the rexis to proper size there. So in the end, we have a perfect size of capsular rexis. Again, here again, because of the movement, the rexis is trying to go outwards. So here again, I give a nick here. And complete capsule, making a small capsular rexis. Now see again what happens when I'm trying to debulk. I'm debulking from this side, going from another port here. So when I'm these things happens when these capsules are friable, they are fragile. So, and because of little movement in topical anesthesia, these kind of things can happen. But you need to be careful that you are able to salvage them. So here I'm trying to convert from here, but I realize that it's better to give a relaxing cut here and then try to finish capsular rexis, because this is, so again I give a cut on this side and trying to take this into the rexis margin. So again, holding it and completing the capsular rexis. So in the end, you have a good overlap of the IOL optic all around, but it's little more this side. So you can always go and secondarily enlarge the capsular rexis. So just last case, what I want to show here is this is a case in which the rexis had gone. This Argentinian flag you can see here. So here, what you're going to do is you're going to give a cut here and try to make the rexis in the remaining portion, which is there. So I give a cut there and use micro forceps to make capsular rexis, so it becomes like a keyhole. So now the question is to do phaco in bag or outside the bag. I prefer to do it in the bag, maintaining closed chamber. So this is and here I'm again maintaining closed chamber, putting OVD before I come out and doing irrigation aspiration. You can see the flutter sign there. Dr. Rohit Prakash has described this. So you know that there's not a wraparound tear. So here even this is a hydroimplantation. So lens goes in capsular bag and there's a little overlap is more this side. So I go ahead and maintain closed chamber and use a scissor to give a snip and enlarge rexis to perfect size and hydro stitch incision before you come out with your irrigation cannula, and this completes the case. So I think if you use these little,
which he highlighted was, visibility, which Chitra also talked about. If you can see better, you can manage the case better. If given an option, I'll not hesitate to stain the capsule again so that things are more visible. And the hooks is a very good idea in those cases also.
Tamil, can you take the next question?
Yes, ma'am. To Dr. Harshal, one other cause for rexis extension is sometimes we see this anterior insertion of zonules. How would you handle such cases? What is your tip?
So what I felt is that anterior insertion, you need to be little careful, but still if you are careful enough and your forces are towards center, you can easily get away through anti-insertion zonules. Otherwise, you can always cut through also, these zonules if you want. Otherwise, as such, they don't cause any problem. If you try to make it with cystitome, of course, you'll have peripheral, centrifugal pressure, which is trying to take it outwards. But if you are using, so one thing is always use forceps. Wherever you have a white mature cataract, anti-insertion zonules, wherever you want good control, forceps is the key. You can
Yes, sir.
always direct the tear wherever you want.
Yes. Dr. Kiranjit, sir?
Yeah, there is a very important point I want to tell about this swollen cataract, in which cases we get a Argentinian flag, is that we make a primary rexis in the center, thinking that we are very much far away from the zonules and equator, but actually we are close to the zonules and the equator, because the pressure in the central part is much more than in the mid periphery. So it makes sense to make a primary rexis in the mid periphery, because while we are making a primary rexis in the mid periphery, the nucleus complex is held back uh, by the central part of the anterior capsule that holds it back. It is like a volcano. If you touch the center and the nucleus comes forwards by a fraction of a millimeter micron, it will split open the anterior capsule. But if you are making the rexes in the mid periphery, the nucleus will not move. And by making a CCC primary rexis in the mid periphery, you can aspirate you can do that dry aspiration from the sub-incisional area and all the quadrants. And after you have done all those things, you can give two nicks in the smaller rexes, and you can make a very big rexis, and you can avoid Argentinian flag in every case. So, and while we are doing it close to the zonules, we are actually far away from the zonules. It is just the opposite.
Yes, yes. So many interesting points for us to mull on. We can now go on to our next speaker. Harshul, that was an amazing talk.
Thank you, ma'am.
Next speaker, Dr. Ramurthy, who's going to give us some nice sound pearls for IOL exchange. So on to you. And we have a lot of questions here.
Can you see?
Calling Dr. Ramurthy, Dr. Suven, I
Can
would
you
want you to
can you
create-
see my
No, sir.
No, we
No,
can't.
sir.
1 minute?
Suven and then Dr. Naren. And unless Shreyash joins, we'll ask Dr. Menu.
Yes, sir, it's visible. Yes, sir, it's full screen.
Yeah. Yeah. Thank you. I'll be talking about intraocular lens exchange. It's primarily a single video that I'm going to be showing. This was a patient who received a bilateral implantation of a spherical aberration-based lens, which gives multifocality, has worked reasonably well in many of my patients. But this particular patient was extremely unhappy, both with the quantity and quality of vision. As you can see here, he has a very mixed astigmatism, has only 6/12 vision, uncorrected in the right eye, needs this kind of a refractive error. Again, he needs additional power also for near vision. And he was just 42 years old. Essentially, he had a fairly early cataract and was very unhappy with both the quality and quantity of vision. Waited for almost 3 to 4 months. He did not settle down, and he was quite insistent on getting something done, and also wanted the multifocality to be reduced. Since this lens was completely based upon a different principle, I decided to go ahead and replace it with a continuous range of vision intraocular lens. And as you can see over here, this is the patient about 4 months later. It's a hydrophilic lens with a hydrophobic coating. And the idea is to get this lens out. It comes with 4 closed haptics, and because of which I have to make I make a 2.8 millimeter incision, and that's essentially high molecular weight viscoelastic going in to bloat up the capsule, the anterior chamber. and giving me adequate space. And that's iris spatula being introduced so as to separate the capsular rhexis margin from the optics of the lens. Mind you, this is just about 4 months old, and it's a hydrophilic lens supposed to be with a hydrophobic coating, but relatively easy to separate it out. And now what a fairly bulky lens, what I'm doing is to bring this lens out of the capsular bag into the anterior chamber. And this was been, that's one side out, and this is the second side that's coming out. And as you can see, the lens is fairly large. And normally I would just make a quadrant cut and then subsequently roll the lens out. But in this case, what I'm going to do is to introduce the secondary lens that I was planning to implant, which is a continuous range of vision intraocular lens, a hydrophobic acrylic lens. And that goes into the bag. It's essentially IOL scaffold I'm using because I'm wary of the fact that this is a highly demanding patient. I do not want any damage to the posterior capsule. So once I have the secondary lens in place in the bag, that gives me the comfort that there is very little chance of damaging the posterior capsule. Of course, placing the lens in the bag poses some challenge because there is some amount of fusion of the capsular bag, but I am able to position it quite properly. And as you can see over here, the secondary lens that's in place, and that's offering adequate protection. Now, of course, we have to be cognizant of the fact that endothelium also needs to be protected. So again, refill with viscoelastic, going through the side port with a lens holding forceps, and I'm getting a firm grip onto the lens. And since, as I mentioned, this is a 4-haptic lens, fairly bulky lens, I decided to go ahead and bisect the lens quite completely. But a C-loop lens, then maybe just 1/4 cut and then rolling the lens would have been quite adequate. I'm completely dividing the lens into two quadrants, hemi segments. Then subsequently, I fill in with the viscoelastic and then get with the same lens holding forceps or any forceps that you choose to get the haptic, catch hold of the haptic. Sometimes these haptics tend to give way when you try this hand over hand maneuver. But then, as you can see, this happening here, but a little bit of the lens is still available for me to get a grip onto this. And then through the 2.8 millimeter incision, I'm able to bring out one half of the lens out. And then I go ahead and address the other segment. Basically, the point I wanted to make here, when you're doing this, your primary aim is to protect the posterior capsule as well as cause as little damage as possible to the corneal endothelium. So placing an IOL scaffold, I think, works very well once you brought out the intraocular lens, the primary intraocular which has to come out into the anterior chamber. And then adequate amounts of viscoelastic, dispersive viscoelastic for the endothelium. And when you want a deep chamber, like when you want to bring the lens out, using a cohesive viscoelastic is a good idea. And again, that's whatever viscoelastic that was introduced being aspirated. And you can see that this lens is fairly well centered. That's almost the end of the surgery. Actually, I did the same procedure for both eyes of the patient 1 week apart. And this patient actually traveled from Africa, Indian settled in Africa, who came for his surgery. 3 months later, came back, and then we did this exchange bilaterally. And as you can see over here, subsequent to the second surgery, this was the visual outcome. Very small cylinder in the right eye, but otherwise very satisfying visual outcome for distance near and intermediate. So even though the first lens was also a multifocal lens based on a different principle, that optics did not work for this patient, but then replacing it with the second lens did play a part. So the pearls for IOL exchange is identify the cause for patient dissatisfaction. If it is a PCO, if it is a bad ocular surface or some macular problem, obviously that needs to be addressed. Do not be in a hurry to replace the lens. Allow adequate time for neuroadaptation. And just in case it's a small residual error and laser Western correction is possible, obviously that's an easier way of dealing with the problem. And consider the primary intraocular lens that has been implanted, the duration for which it has been in place, and account for the capsular adhesion that might have developed. Use both the preoperative biometry before the first lens implanted and the biometry in pseudophakic mode. And as I mentioned, measures to protect the endothelium posterior capsule. And always this is already a dissatisfied patient with high hopes. Give a very guarded prognosis and then deal with the patient. Quite often you might come out quite successful. Thank you so much for your kind attention.
That was a wonderful presentation and great tips to have how to manage this difficult moment. Just one question with you before we go on to the other panelists. For a plate haptic versus a loop haptic, in what way would your dissection differ, dissecting the IOL out?
Actually, if it is a plate haptic like the Zeiss plate haptic lenses, which is also a hydrophilic lens, I would not even section the lens. What I've had two lenses I've explanted, just catch hold of the haptic and then one of the plates and then pull the lens out. Even through a 2.8 millimeter, the entire lens folds on itself and comes out. But as you saw, this was not really a plate haptic lens. It has a four closed haptics, and I've never explanted this lens before. So I thought it would be quite traumatic to pull this entire lens out, even if I have to roll it out after a single cut. So basically, I decided to bisect the lens, and then it worked well. But even then, I took all the precautions to protect the endothelium.
Tamil, can you take the next question? Yeah. Yes. Yes. Go ahead.
Yeah. So, which lens was this? This was Proxa or just
No,
Minivel?
Leave that.
Leave that part. No, we don't discuss
No,
that.
it's a spherical
No,
ablation.
I also had same problem with one of the patients. This is a problem which I also had. I also had to expand the same lens.
No, I had.
Patient was having a lot of photic glare. He was totally unhappy.
Correct. You're right in the sense that, we are very enthusiastic about these lenses. We thought, this is a lens which seems to give reasonably good vision, no diffractive rings, no splitting of light. So maybe dysphotopsia will not be a problem. But though the initial experience was good, but as we placed a few more lenses, we have actually had 3 patients who have been quite unhappy with the outcome. I think the interplay of positive and negative spherical aberration doesn't always work well with all patients. So there are very stringent criteria we follow, and of course, now we are quite wary of these lenses and use them in small numbers.
Yes,
the only saving grace was that it's a hydrophilic lens, which is, even you can expand after 2, 3, 4 months easily. Had it been hydrophobic, it's really becomes very difficult sometimes, no?
Use the capsule. Tamil, can we move on to the next question?
Yes, to Dr. Titial, sir. Like if the optic haptic adhesion is very dense, if you're not able to lyse it, and what would be do you advise to cut the optic haptic junction, or how do you proceed, sir?
I think the first attempt should be to gently dissect out with the help of viscoelastic possible. Sometimes, if you go clockwise, anti-clockwise movement, sometimes these haptic may slip out. If that doesn't come out, then no harm leaving the haptic behind also. Simply cut like we had this, closed loop haptic. We can just cut it and leave it there also. It won't cause any problems rather than trying to damage the capsular bag, which is very important as such. But I've seen most of the time, if you give little more time, gentle dissection with the help of viscoelastic, ballooning out the peripheral area, then dissect with the dissector, most of the time it might come out. But if it doesn't come out, no harm leaving the haptic behind. I've left many haptic like this also.
Dr. Shrish, where would you start your dissection when you have to remove the lens and the rest? It is not going to just come out of the bag easily. Would you do it under the optic, or would you start at the optic haptic junction?
It again depends on the type of lens, the material. So hydrophilic lens, it slips out easily. Hydrophobic only is the problem, and this is actually a rare indication of IOL scaffold. So it was nicely demonstrated, and because we use this IOL scaffold for various other reasons, like managing a PCR and managing a nucleus in a PCR, or a hypermature cataract when there is no cortical support. Disengaging these optics and haptics may be difficult in hydrophobic acrylic lenses. You have to inject first. You separate the capsular adhesion at the capsular margin, that is the CC margin, using iris spatula. Inject visco through wherever there is some ledge. You can just inject visco and try to separate it mechanically, and even go behind the lens and try to separate it either by injecting visco or with the iris depositor. So most of the cases you can disengage them, but as Dr. Titial mentioned, if at all the haptics are adherent to the equator, then you can leave it. You can just cut at the optic haptic junction and replace it with the new lens.
Yes, Dr. Kiranjit?
Yeah, in some cases, in spite of very good, you try to do a very good dissection of the IUL and haptics from the capsular bag, and but you don't succeed, and ultimately you end up bringing out the capsular bag out of the eye along with the lens. So you have to be ready with a standby lens. That is very important
Yeah.
because it is not 100% surety that you'll be able to exchange the lens.
Has anybody tried feeling the need to do a removal of an IUL in an open capsule? Any tip to give for that?
Oh, I think Naren wants to say something. Let
Yes,
him say,
Dr.
then
Naren?
I'll talk.
Yes.
Yes, ma'am. So I just wanted to share a small tip. I don't know whether it's already covered or not, but one of the things which normally I usually use is capsular hooks. That in the region where the haptic is, I use capsular hook and then place it and then use the viscoelastic, and everything else is similar. So that what happens, there's always a counter traction to that particular area. It's constantly, pushing the capsule back. So that's one more way where we can handle these cases a little more easier. Thank you.
I have, as
So,
regards your question,
yes.
Chitra, I mean, regarding, I have had a situation where a patient who had a PCR and a multifocal intraocular lens, which was not really in place, and the patient was extremely unhappy with the visual outcome. We had to replace it. So basically, we had to exchange the lens. So basically, we did inject, already a good vitrectomy had been done during the primary surgery. So injected dispersive viscoelastic under the lens, and then tamponaded the PC, and then subsequently brought out the lens, and then placed a three-piece lens. So obviously doing a good anterior vitrectomy, tamponading the PCR, and then subsequently extracting the lens is possible. Occasional cases where yak capsulotomy has been done in a hurry also have sometimes present with a very unhappy multifocal intraocular lens patient. This can again be dealt with, though it's not it's best avoided. And sometimes if it's a very small rexis, what I find is what is adherent on the optics of the lens is very strong. And you can make a small nick over there, something like a capsular rexis. If you are able to create a opening, then beyond the edge of the rexis, the adherence of the capsule to the optics is a little less. And once you have created that small nick, then you can go in with the high molecular weight viscoelastic and then create a plane of dissection and get this lens out. So these are just various ways I'm sure all of us try depending on the situation.
Thank you very much. We go on to our next speaker, Dr. Suvin Bhattacharya, who's a consultant of Nine Eye Center and MedInvent Devices. And we know that he's truly an innovator and unimaginable levels his BX ring has gained popularity. So I felt he should be just the person who has to just tell us in 4 minutes the steps for easy insertion of a BX ring. On to you, Dr. Suvin.
Yeah, thank you, Chitra. I somehow can't find it.
And we would combine BX ring and the next talk on iris hooks.
Can you see my presentation now?
No, we
Can
don't.
you see?
Sir,
Should I start
Yeah.
go to
till then, sir? Or
No. It shows my screen as sharing.
go to stop share, sir. Again, you share it, sir.
Yeah,
Choose
I'll share again.
presentation.
Yeah, I'll just share again. Yeah, one
Yes, sir.
second. Okay, the permissions were not there.
Yes, Dr. Rishi, you would be talking next. And I think, Suvin, you need time. Let's
No, I
have
don't
it.
need time. I'm open over here now. What's
Okay,
happening
right,
over here?
right. Yeah.
This is
Okay, continue.
Well, Morgan, something with the permissions. Can you please work on that? I don't know. Gone out of Zoom.
Sir, open your presentation, sir.
Sorry, Rishi. Dr. Naren has to go next. But
I'm opening.
oh, Rishi was there in the beginning itself. Sorry. Naren, is it okay if Rishi goes before you?
No problem.
Yeah, but in any case,
Yeah.
I will not be able to because I don't know what's happening over here. I just can't.
No,
I found the screens.
Dr. Suvin, I'm going to ask Vel Murugan to help you. And we'll go on with our next speaker and we wait for you to join us soonest. So
Sure.
we go on to our next speaker, Dr. Rishi Swarup, who again needs no introduction. Rishi Swarup has a great practice in his Swarup Eye Clinic at Hyderabad, an extremely dynamic surgeon, and I know he would do a wonderful job of his talk, Rexis in fibros, anterior lens capsule, and subluxated cataracts.
Thank you,
Most
Dr.
importantly,
Chitra.
he has adorned innumerable of my ARC webinars, and has had me always wanting to keep calling him back. Thanks, Rishi.
Thank you, ma'am. I'll try to finish this topic in 4 minutes. Actually, there's lots to cover. So I borrowed a few videos from some friends because I don't have so many fibrous capsules, but I hope I try to cover most of the things in this. Okay, so the mandate given to me by Dr. Chitra was to cover these two conditions in which Rexis can be certainly challenging. And why is it challenging in these situations? I hope my slides are visible.
Yes.
So in a subluxated cataract, we know that because of the lack of zonules, there's poor countertraction. And because of that, your Rexis can end up becoming small or eccentric or can easily run away. And of course, that can result in other complications. And in a fibrosed capsule, the capsule is basically adherent to a fibrotic membrane. And therefore, when you're trying to do a Rexis, it may get stuck in the area where there's adhesion. And if you try to use excessive force using a needle or a forceps, you may end up tearing the Rexis if you don't use any additional tools. And that, of course, can result in other complications. So these are the two main problems that you face. So I'll just cover a few videos and some strategies for both of these. So fibrous capsule, some of the strategies are if it's a focal area of fibrosis, try to go around it if it's possible. Even if you need to make your Rexis a little eccentric, it might be a reasonable thing to do. If it is a very extensive area of fibrosis, then one of the strategies which has been described is to create a small CCC in an area which doesn't have fibrosis, and then insert some sort of a spatula or some instrument to dissect the fibrotic membrane of the capsule. It may not always be possible, but if you can, then it's actually possible to do a good Rexis and complete the surgery safely. You also can complete using sharp instrumentation like scissors or a vitrector in the areas where you have adhesion instead of trying to pull with a forceps or a needle. And of course, if you have access to technology like Zepto or a capsule laser or a femtosecond laser, that makes the job a lot easier. So we'll just show some videos for that. So this is one of my colleagues trying to do a Rexis with a needle. And of course, she got stuck at the point where there is a fibrosis, as you can see. And if you try to keep pushing, it will tend to extend. So that's exactly what's happening here. And you can see in the attempt to try to pull it with the forceps, it tends to run, but luckily we stop at the right time. So the strategy here is to try and go from the other side where there is less fibrosis. So we initiate a new cut from there and then just go all around and then try and join up around the area of the fibrosis. In this particular situation, that worked quite well. So I'll just run through that quickly. And as you can see, we could complete that. So this is a video I borrowed from Dr. Deepak Meghur. It's a very nice video in which he's demonstrated the use of scissors to kind of create a piecemeal rhexis. So you can see wherever he's pulling, it's tending to break away because of extensive fibrosis. So he's used multiple cuts to kind of just create like a small central opening first, then put viscoelastic underneath the capsule to try and free up the attachments between the lens and the capsule, anterior capsule. And after that, he used micro scissors to kind of micro forceps to kind of try and complete the rhexis, and in the end gets a very good rhexis, which is good for doing a safe emulsification. So idea is to use scissors if things get stuck, and that works quite well. This is a video I borrowed from my friend Dr. Gaurav Luthra, in which he's demonstrated the use of femtosecond laser. So one of the important things to keep in mind is that your rhexis cut should be deep enough to be able to cut the subcapsular fibrotic membrane. So if it is not cutting the membrane completely, then there will be adhesions, and then you'll end up in the same situation where the adhesion is holding the rhexis back. So you need to cut through the membrane, which you can luckily see very well in the intraoperative OCT, which accompanies most of these femtosecond lasers which we use in cataract. So you can see it's cut through the membrane quite nicely, and it comes off quite. There's one area where there's an adhesion, but you can see he's pulling it and it breaks away quite nicely, and you get a nice perfect round rhexis. Similar thing, sorry about the audio here. But similar thing you can see is being achieved here in the fibrotic capsule with the Zepto.
Doctor, 1 minute more.
You have at one point. So you can see the fraction being applied, and you can quickly get a kind of a precision pulse from a nitinol ring, which cuts a perfect round rhexis. So this is probably one of the few conditions where a Zepto really has an advantage, because it cuts perfectly using thermal energy. Capsule laser is again another laser which is available, in which an external laser is applied, and it gets a perfect round rhexis. So may again be very useful in these kind of cataracts. So this is a video I borrowed from Dr. Zai Kelkar, who has this particular technology. Subluxated cataracts, some of the strategies are use of high density OVDs like Viscoat. You want to also push the vitreous back, because that can interfere with your rhexis and cause complications. And of course, you want to flatten the capsule so that the rhexis doesn't run away. Use of specialized instruments like micro rhexis forceps. Double-handed rhexis giving counter traction is very important. So you can use a second instrument or capsular hooks. You can keep inserting them periodically. Repeated injections of OVD and centripetal pull in the area of zonular weakness to prevent an extension. And of course, again, the same Zepto, capsule laser, or femtosecond. The audio here. So you can see the use of high density OVD being used, which is an important thing. That's specifically demonstrated that. So when you're initiating the rhexis, be a little eccentric, because your lens is moved to one side. So if you're trying to be central, you will have a problem. And of course, use micro scissors. And here I'm just trying to show the centripetal force in the area of the zonular weakness is very, very important to prevent the run out. And of course, one can put capsular hooks at this point, or some second instrument to give counter traction, which I am not using in this particular case, but that can be used very nicely. Again, femtosecond laser, video I borrowed from my friend, Dr. Abhijit. I'm sorry, why didn't that play? Yeah, so you can see, you can move the rhexis eccentrically according to the subluxation. And you can see here, you get a perfect, nice round rhexis. And after you remove the capsule, you can apply these capsular hooks and complete your phacoemulsification safely. And this is finally, again, demonstrating the use of Zepto for subluxated lens. Also, you can use it. So you apply suction, and then you give this pulse of energy, and you get a nice round rhexis. And after you've done your emulsification, you can insert the lens. So those are just some strategies for fibrous lens capsule and subluxated cataracts. Of course, this is a big topic, and lots of things can be added. If we have time, I can show one video which I borrowed from my friend Abhijit, but if you're out of time, we can skip it.
No, I think we'll take a lot of questions from you too.
Sure.
A wonderful set of videos you have shown. I know it's a huge topic, which I asked you. Do you think, Rishi, fibrous capsules have less tendency to extend or wrap around? Do you feel?
No, ma'am. I mean, it depends on how you're dealing with it. If you're trying to pull it vigorously, of course, it will extend. So the trick is, the key is don't try to force it if it's not coming easily, and maybe use a cutter or a scissor and just complete it in the area of the fibrosis and then continue. Or you could just try to dissect the fibrotic membrane of the capsule in the area of the adhesion, even after you've initiated the rhexis and not completed it. And often that works.
Dr. Minu, what step would you take to, in a subluxated cataract, to lose out on the red reflex when you are making like staining with trifine blue? How would you go about that?
Yeah, first thing is, as he said, no, we use the viscoat to push the vitreous away from the capsule, and the second thing is to use sodium hyaluronate on top of the capsule, and then have a little saline over the anterior capsule, and then paint the trypan blue drop by drop on the capsule and move it along the cannula so that it can stain the central area, and definitely be eccentric from the area of dialysis so that you have a good rim of at least 2 millimeters beyond towards the area of subluxation. One more, just a smaller point was when we cut with the scissors, if you cut through the fibrotic area, it's fine. It doesn't extend. If you make multiple cuts also, if you make multiple cuts, there are going to be multiple nick areas which are going to be weak. But if they are inside the fibrosed area, it doesn't extend. But if you cut from the non-fibrosed area into this one and make another cut, there will be a small weak area which can have a tendency to extend towards. And also in femto, does this femto actually penetrate through these kind of white fibrosed areas? I am not very sure. Other Ramur sir, Naren, can you just explain? Will it penetrate through this very dense white capsule, fibrosed area?
I really feel, just like we talk about intumescent cataracts, the capsular fibrosis is another indication for using a femto laser. As you rightly point out, it's a absolutely dense fibrotic plaque. It doesn't help. But otherwise, usually I have an offset of 300 microns above and below the capsule. In these cases, I extend, as Rishi also said, I extend it to 500 microns on either side because it's a thicker area of capsule that it has to go through. And what you will never get a free-floating rhexis in these cases, but what you get is a nice template. So subsequently, we stain the capsule, and then wherever it's free, you open it up, and then gently you are able to go along and get a fairly round rhexis. Of course, whenever you feel there is excessive resistance and it's not going through, then you use a scissors to go through. But I think it's not that it sorts out all cases, but it's an important adjunct that we have, and I won't hesitate to use it if there's a fibrotic capsule.
Kamil, can you take the next question?
Yes, ma'am. To Ramurthy sir, does the femto capsular rhexis rim withstand the forces of capsular hooks or the iris hooks as the capsular rhexis, or?
I think it has been set to rest that the femto capsule rhexis is somewhat weaker than what's created with the needle or scissors. Basically, we do understand that was something the prevalent idea when the energy levels that were used was too high and there were aberrant spots, and you used to get postage stamps type of cuts. But now with the usage of contact lenses or a fluid intermediary, the amount of energy levels are also much less. So it's a moot point as to which is stronger, but suffice it to say whether you create with your needle or whether you create with a femtosecond, the usual maneuvers of using a endocapsular rings or segments or capsular hooks, all these rhexis really withstand. I would not feel that I won't claim that the rhexis created by a femtosecond is stronger, but I don't think, at least practically, it's any weaker than what is created with the needle.
Yes. Thank you. We shall go on to our next speaker, Dr. Naren Shetty.
I'm ready. Chitra, I'm ready.
Oh, sorry, Dr. Suven. Yes, Suven, you are back to you. Sorry. No, sorry, Naren. Suven had this video ready.
No issues. No issues.
Yeah, can you see my screen now?
Yes, yes, yes.
Not going to full screen. You can see my screen, correct?
Yes.
It's not good. Yeah. Yeah. Thank you, Dr. Chitra, for this opportunity. And so I'll be speaking on the BX People Expander, the steps for easy insertion. I do have financial interest as an inventor and owner director of the company. And I thank Dr. Deepak Magur and Zain Khatib for sharing their videos. So the first step that I would like to emphasize is to differentiate between an elastic and a non-elastic pupil. So elastic pupil is like a rubber band, where a non-elastic pupil is like a string. So you need two Kuglen hooks to tear them. Otherwise you won't get past it. And the next is where to inject viscoelastic. So if you inject viscoelastics onto the iris, it plasters the iris onto the pupil, onto the lens, and that doesn't leave space for the pupil expander. Instead, if you inject viscoelastic under the pupil margin and you lift it off a little, you have enough space for the pupil expander. So you keep the anterior chamber underfilled and you inject viscoelastic under the pupil margin. Now we could check the elasticity of the pupil before starting by just injecting BSS through the paracentesis, and you can see the pupil momentarily expands. And that is enough evidence that the pupil is elastic. Whereas in a rigid pupil, you see how much ever you inject over here, the pupil is not going to expand, and it is you need two Kuglen hooks to kind of tear that fibrotic ring, and then you have a reasonable size pupil to go ahead and put your device. So these are the few steps. So inject viscoelastic under the pupil margin and lift it off a little. And then we put a blob of viscoelastic on the device so that it doesn't jump out. And then we tuck alternate flanges under the pupil margin. You've already created space, so it's not difficult. And that is very easy. So you have a nice hexagonal pupil. Then the rest of the steps of capsulorhexis and phacoemulsification are routine. And this allows you enough visualization a little. And there you are. Only while placing the IL, we need to be careful that we place the trailing haptic into the bag without displacing the device. Now, the easiest way to remove is this: hold a flange, advance it centrally, and disengage it to the two notches on either side, and then draw out the device. If it's a rigid pupil, like here, this is Deepak Magur's video, you can stretch it a little, and that makes your job of tucking the flanges much easier, and you have a good sized expansion for you to go ahead and perform the surgery. Now, you can even stretch after in a partially engaged BX. Now, you can see there are two flanges which are engaged, and I felt that this would be a little tight. So I went ahead and stretched this, and now I'm going to be able to put the third flange very comfortably. And that will offer a very good size of the pupil for me. Now, this is a situation where the three flanges are already tucked and it was a rigid pupil. So this is buckled a little. So you could even stretch over with all three flanges engaged, and you can have a well-sized pupil. Now, removal of the BX is, this is the wonderful part of it. You can remove it through a 1 mm side port incision. Just draw, keep the flanges, take the flanges centrally and draw it out. Now, you can remove the BX under irrigation. Be mindful to just keep the irrigation enough to keep the anterior chamber formed, not have the iris prolapse. That's the key. And you can, and this is a wonderful technique by Dr. Zain Khatib, where you can just, tumble out the BX after disengaging the flanges. So to summarize, the BX is a simple, safe, affordable device. It's a single plane hexagon with notches and flanges. It's ultra thin. The smallest incision size is actually 1.2 millimeter and requires 0.9 millimeters only for removal. Snagging of incision, there is no injector required. And the BX forceps, of course, offers a much better control. It's a very short learning curve. Thank you very much, Dr. Chintra, once again.
Dr. Sumit, what is that main difficulty a beginner would face when inserting your ring? You have anything to add besides all that you have said?
Beg your pardon? I couldn't get your question. I'm sorry.
Main mistake for a beginner when he's trying to insert your ring?
Yeah. I don't see actually, most beginners actually start by just seeing videos. So it's just it has got, you don't need any it's not rocket science over there. You just need to hold the flange and take it inside. Now there is no struggle over there because it's a very thin device. Yes, what we need to do is place the entire device in the anterior chamber before we start tucking the flanges. If you leave part of the device in the incision, then tucking might be a bit difficult and the flanges can get untucked.
Yes. Tamil, can you take the next question?
Yes, ma'am. Dr. Suvin, like any challenges if you're going to insert the BX ring in the middle of the Phaco, if you're going to experience meiosis or?
No. Actually, since this was 4 minutes, I didn't cover that part. It's actually the safest device with in the presence of a capsulorhexis. So because you can see as you engage the flanges, you can see the engagement and you can draw the flanges towards the periphery. And if you face any resistance, you know you've engaged the capsulorhexis. Whereas in a device like a Mulligan ring, the opening is on the side and you really can't see it. Here the notches are open and facing you. And every time you push it to the periphery after tucking it, you are having instant confirmation that you have not engaged the capsulorhexis. So it's very safe.
Dr. Meenu, if we are going to use iris hooks and the pupil is small, so what, and you are halfway through the Phaco as Tamil said, so then how would you, what would be the first thing you would do?
You mean during Phaco, pupil becomes small and I want to put iris hooks?
Iris hook, yeah.
Iris hooks. Iris hooks is also safely done. Only thing is we should remember that the rhexis is beyond the pupillary margin. And when you're hooking, you can hook the rhexis margin also. So what I do is I put viscoelastic first, elevate one area where the first hook is going to be placed, and then hook the iris and lift it up and see and pull. And then you will see the bag moving if you have engaged the rhexis also. And if it is freely moving, elevate and pull. And then go get it beyond the rhexis margin. Once it is beyond the rhexis margin, the next one can be just taken towards the first one and then sweep it along so that you are off from the rhexis margin. So that is the easiest way to cover this off. One small thing, Suven, the beginners, for the beginner, when holding on to the segment which has rings, three rings. I have seen people holding that and struggling to engage the other segment. So these are things we may not expect, but these are things which can happen. So it is ideally you hold on to the segment which has the three rings on the center of it and tuck that in, and those things have to go in. Even the other part can also go underneath if you catch that. But these rings are for holding and tucking them underneath. And you can either tuck one side of the flange and then tuck the second side. But later on, you can go with one go and tilt on one side and get one in, and tilt on the other side and get one inside. So that is the technical.
There's just a little bit of supination and pronation which is there, and you need to hold those tabs. Just to add to what Meenu said about iris hooks, what I do is if I'm using an iris hook and in a Myos eye, which I actually rarely use iris hooks, but if I do use, I can use a second instrument from the other side port and tent up the iris, tent up the pupil margin, and then use the iris hook. That way you are absolutely sure you not engage the capsulorhexis margin. Use a second instrument from the other diametrically opposite side and tent up the iris.
Yeah. Srish, how would your incisions differ when you're making a side port, whereas it's an incision for an iris hook? Anything different you have for the people, attendees to tell?
I usually make 4 side port incisions. It should be at the limbus. If you go more into the cornea, you're going to tent up the iris, so that is not good. And so it should be very close to the limbus.
I think it should be a stab incision if it's to be for the iris hooks, as against a small tunnel incision for a side port. And the other practical question which we could ask is, Tamil, can you take the question? If you have to, the pupil is very small and you want to make a larger rhexis, this is a very simple question, but any of you, Naren, could you tell? You want to make your rhexis and the pupil is small, you want a larger rhexis. And besides iris hook, what else would you do?
I think any of the pupil expanders, whichever the surgeon is comfortable, they can use, ma'am. And then if it is definitely too small of a pupil and you need to, create a very good or normal size rexus, you need to use one of the pupil expanders. Once you have good exposure, then do your rexus. And one more tip on if at all you have completed your rexus and then the pupil becomes small and then you're not sure on how to do. At that point, ideally, it's better to avoid iris hooks. One more option is to use a capsular hooks. Capsular hooks can act as both. If at all the capsule gets nicked, nothing happens, and plus it can pull your iris too. So that way, you're safe, ma'am.
Okay, thank you.
Madam,
So
your question was how to do a rexus under a small pupil without the expansion device, is it not? So
yes,
that was what I understood. So we can use a Y hook or a Coughlin hook to
yes.
retract off the iris wherever the leading part of your rexus is, and visualize those areas where you are tearing, and also continue and complete the capsule rexus.
And in the first step itself, ensure that the trifant blue goes right deep into the under the pupil also, so that it's stained also. So we go on to our next speaker, Dr. Naren Shetty, who heads the Department of Cataract and Refractive Services at and also is the Vice Chairman of Narayan Nethralaya Group. And his topic is going to be cracking the leathery posterior plate. So on to you, Dr. Naren.
Thank you so much, ma'am. Once again, I would like to thank for this opportunity from Dr. Chaitra ma'am and Ramoti sir. Today, I'm going to talk about pearls in cracking a leathery posterior pole or a plate. Now, before we do that, we really need to understand an opponent. What is really happening in a hard cataract or a black cataract or brown cataract? Now, you see the hardest part of the lens is in the center, right? And if you look at the lens, it is like an onion. If you look at the superficial fibers, it actually goes and finally joins, or it is a part of the posterior plate too. Okay, let's keep this in mind. But whenever we think about or we start, okay, doing a hard cataract, before we chop, we say, okay, I have to go very deep. I have to do a very deep chop and then do it. But actually, you're trying to, when we do a deep chop, you're trying to separate or, divide the hardest part of the nucleus, which becomes very challenging, especially in these brown or the black cataracts. But instead of doing the deep chops, actually, what I personally do is I do more of a superficial chop. So what I do here is if you separate the superficial fibers, which will be hard enough in a brown or a black cataract, that if you separate, that will go around and it will open even the posterior plate too. So this makes it so much more easier to separate the posterior plate than going through the hardest part of the nucleus. So the same thing. So by doing this, what happens is we insert less stress on the zonules because you don't need that much force to separate these part of the nucleus. It's not as hard as the center, and also you really isolate and you can easily separate your posterior plate. Now, the other trick in chopping in hard cataracts is do not do long chops. When you do long chops, you have a tendency for the lens to tilt. And it's something like tearing a piece of paper. You have to hold closer. You have much more control than holding a little apart and then trying to tear it. It becomes a little more challenging. Always keep the dialer just in front of the tip and then pull it along towards the tip, and then you'll achieve a good crack. And once you've done your initial stroke, you need to go and separate the different levels of the lens so that you easily separate even the posterior pole too. So if you look at this now, after the first stroke, then I go deeper, separate, deeper, and separate. This is how you have to release and make sure that even the posterior plate also is separate. Now let's look at how this. Now you can see this is a very hard cataract. I've held it superficially just in front of the tip. I make a stroke towards the tip, and then you can see the central hard nucleus being isolated from it. So you can see it. I hope you can see this area. This is the central hard plate, and this is just a superficial chop. Every cataract becomes super easy. Doesn't matter how hard the lens is. Now see, here is one more case, and we can easily replicate in every case. So again, I clear off the superficial cortex. And once I've done that, I hold, make sure you, impale the nucleus into the superficial fibers just in front towards the tip and then sideways. And then again, you release, go a little deeper, release deeper. So that way you can easily separate even the nuclear plate. Let me show just one sec. Okay. So once you're separated, anyway, I think the rest of the pieces, one of the trick in hard cataracts is you need to make as small pieces as possible so that it's much, the emulsification, it looks like NS2, but actually it's NS4 grade cataract. That is the ease at which it's able to emulsify only because, I made a smaller pieces of the phaco tip. Now, if at all, you're finding this particular technique very challenging, you can always use a loop. It becomes, if you master this using this particular instrument, it becomes really easy in, separating the thick leathery posterior plate. And then what you can do is, basically what you do is once you insert it, you have to make sure the wire is just below the capsule, expand it completely, and then start rotating till you see the wire reflects from the posterior part. Once you have done that, use your dialer to steady the lens, and then within just a second, you can complete your chop, and then you're good to go. So basically, the take-home point is, I personally do it like this. Every surgeon has his own technique of handling these cases, but I always do a superficial chop and always keep the chopper just in front of the tip and move towards the tip and then separate. This will become much more easier in separating your posterior plate, and the rest of the surgery becomes so much more easier. Thank you so much for your time.
Thank you very much, Dr. Naren. We shall take Dr. Shreyash's talk and combine the questions for both the leathery cataract and the Morgagnian. So we have Dr. Shreyash, who is a consultant cataract, cornea, and refractive services, and who seems to have great interest in the business of ophthalmology too, along the way. Is going to be talking on nucleus management in Morgagnian cataract. On to you, Shreyash.
It's nice to follow up after Naren's talk, where I think he covered some very important aspects of managing a hard cataract. And really, there are some small differences that I would like to highlight when it comes to a Morgagnian cataract. So essentially, Morgagnian cataracts or hypermature cataracts can also be associated with a hard nucleus, but often the cortex has really become milky, and you don't really have the kind of support that you require. They are very often associated with slightly weaker zonules, and there is a greater amount of laxity, and laxity not just of the anterior but also the posterior zonules. So there is a kind of trampolining effect that the bag can have during your phaco, and they can also be associated with a fair amount of anterior lens capsule fibrosis. So these are all very common, consistent features which you find in Morgagnian cataract, and this is a patient who has all of those features. So in the rhexis, what you do is you really go around the area of ALC fibrosis. Sometimes if the fibrosis is straddling the area where your rhexis would pass, you could make a vertical cut there with your micro scissor and then continue. Now, the challenge in these cases is getting a good hold, because there is no support, there is no epinucleus and cortex which is available. The nucleus tends to rotate. As you can see here, as I'm trying to get a hold, the nucleus keeps rotating around. And in these cases, again, the vertical chop doesn't work very well, because you will end up separating the nucleus from your phaco tip. You'll be dislodging the nucleus from your phaco tip when you try to do a vertical chop. So in all these cases, what really works is a horizontal direct chop. So wherein you get a hold, go around and hook the nucleus. Now you have sufficient space in this bag. The bag is usually, even though the nucleus is fairly large in this particular case and can be smaller in some of the patients with the Morgagnian nucleus, but it is important that you chop it down into multiple pieces. The idea is to have as many small pieces as possible before you start emulsifying, because if you start trying to drag the nucleus out before you've started separating, that is when the already weaker bag tends to get stretched more in one direction. And I just showed that small bit to show that refill with viscoelastic to keep the bag down, because there is a laxity, tends to be a trampolining effect of the bag while you're doing your phaco. Now, moving on to another situation where this is a hypermature cataract, but the pupil was also a little bit on the smaller side. A regular phaco probably will be able to get away with it. But whenever you're faced with some difficult situations, go for any pupil expansion device of your choice. but it's important to have good dilatation because you need to have a sufficiently large rexus and be able to visualize right up to the periphery. And very often you encounter some challenges. And in this particular case, as you see, once that milky fluid has come out, you see that it's a very hard nucleus, almost a black cataract. And in this particular case, while I was able to get a good rexus, but as I move on to the phaco, you will notice that while attempting one of the chops, there was a slight ALC tear. Now, once I do a slight visco filling up the bag, you can see that the nucleus is actually slightly tilting down. This is not because that the bag is weak, but there is so much space that actually the nucleus is tilting down into the bag itself. So the same problem, getting a hold will be a challenge. And once you get a hold, now as you can see here, as I'm chopping, in that area, I have nicked the rexus and this ALC has opened up. Now, this is a situation where it becomes quite challenging. You may have to step back and think whether you'll continue with a phaco or actually convert to an SICS. But very often, if you follow the regular principles of chopping, that is, since you have a greater amount of space, you can actually tilt it forwards a little bit, and the chop can actually be a little more anteroposterior so that you're not putting too much stress on the bag. Only when there is a greater amount of downward force, if you're trying to divide the nucleus or trench the nucleus, that is when this rexus tend to extend. And of course, you can also put in the IOL at a suitable stage when the bag begins to trampoline and use it as a scaffold and then remove the final one or two pieces. You can either use the CTR. In this case, because there was a rexus extension, I have not used a CTR, but you could use a CTR as well and complete the case successfully. In a case where you have a very small nucleus, you could even do this IOL scaffold technique where essentially once the rexus is done, you can actually wheel the nucleus out into the anterior chamber, put in an IOL, and then complete the phacoemulsification. This is not generally my preferred go-to technique, but this is just for demonstration in this case. Because here, mind you, even though the nucleus is small, it's very hard. So the entire phaco energy is actually going to be quite anterior, and this can be a little detrimental. So not a standard go-to technique, but yes, this makes it a little safer in the sense that, yes, you will have less chances of injuring the bag. But this could also be one option that you consider. But in all these cases, I think the take-home is use a good horizontal chopping technique, hook around the nucleus, have a slight lift the nucleus upwards and ensure you're causing less stress into the bag and towards the zonules. And all the forces should be centripetal towards the center of the nucleus and not directed towards the periphery. And unequal forces towards the periphery, again, are a danger, wherein one side of the zonules can get stretched and leading on to a ZD, which will progress very quickly in these patients. Thank you so much for your attention.
Two wonderful set of talks, both Naren and Shreyas. So we just take some questions and we have two more speakers to go. Dr. Ramurthy, would you have a viscoelastic of choice for these hard cataracts, whether it was Naren's or and how often would you say you should replenish it? Very basic question.
I have my own way in the sense that I always paint the endothelium with a dispersive viscoelastic, usually containing chondroitin sulfate. And then just because it's thermogenic, I don't want to activate my phaco in a pool of dispersive viscoelastic. So I put a HPMC right on top of the lens and then go ahead with the procedure. And whenever it's taking some time, I do not hesitate to replenish the viscoelastic, especially coating the endothelium constantly with a dispersive viscoelastic of good quality is extremely important.
Kamil, can you take the next question?
Yes, ma'am. To Dr. Naren, how much of lateral separation is safe? I felt that in all your cases, your right hand was almost stable and was just using your left hand to separate the nucleus laterally. So what do you advise when you're doing a hard cataract?
So the whole point is one of the things is it's not just lateral separation, it's also your phaco probe should go up and the dialer goes slightly down. So it's a combination of not just lateral separation, and always when we divide these kind of cataracts, one of the things which I tell all my students or fellows under me is we have a tendency when we're trying to chop our tendency is when we divide, we push the dialer down. That's when we break the zonules. That is something that we shouldn't. We should always imagine that when we're doing, you have to think that you're trying to rotate the lens. So that way it's, it is within the bag and it doesn't damage the zonules too much.
Dr. Anurag, you are there, no? Dr.
Yes,
Anurag?
ma'am. Yes,
Yeah.
ma'am. Good evening.
I think we should have not spared you so much as we did this time. Some of these very hard cataracts, there are very multiple small pieces which go and hide behind the iris. So when you're doing these cataracts, how do you ensure that you prevent this occurrence? And if it has, how do you ensure that these places are taken care of?
No, I play around with my parameters a bit when I handle hard cataracts in particular, because the one thing that we have to remember is chopping is the first step in phacoemulsification, and we have a pool of viscoelastic to cover and protect the endothelium, and we are going very deep in our maneuver. So what I do is I don't depend on the shelving movement of the nozzle completely. I do add on a bit of longitudinal to it. So I keep my IP switched on, and the IP is full blown. It is 90% vacuum, 10, 20 pulses per second for a hard cataract, as Naren showed us. And then the ratio between longitudinal and torsional is around 1:1. So the moment it reaches 90% of preset vacuum, the longitudinal phaco starts operating. That enables me to dig deep and go into that sweet spot of the nucleus where it can be held and then can be separated. And the other thing I always do is once I achieve crack till the center from the periphery, I rotate it 180 degrees, go to the other side, complete the primary chop first before attempting the secondary chop, so that at least I have two completely separate heminuclei. Just like Naren showed, some of these cases, there is a very central and extremely hard, unchoppable portion. I tend not to have it in my cases because once that very hard endonucleus separates from the rest of the nucleus, what you don't get to see is the cleavage plane and how deep it has extended up to the posterior plane. So once that small discoid is elevated, you separate it and you consume it, you find that it's a flower petal pattern of crack with the center attached still. And if you find that, you have to find some way of going underneath the nucleus a bit, push in some viscoelastic, catch that portion so that the whole pies are properly separated from one another. Then it becomes very difficult for you to dislodge them from the gap and consume it. The idea to prevent this cheese wiring and the pieces getting lost underneath the iris or even underneath the thick arcus of the cornea is just to make sure that the pieces are large. And when you consume it, your flow rate should be enough to ensure good followability so that the whole piece gets attached to the phaco needle and gets phacoed and consumed as a whole, and small pieces do not fly off. There, I would advise not to use the chopper too much because people have a tendency to feed the nucleus into the phaco needle. Not to do that much and rely on your followability, rely on your fluidics and dynamics more so that these pieces don't fly around.
Dr. Shreyash, you have anything else to tell? These very tiny pieces which could get missed out, how would you handle them? You or Meenu Mathan? Yeah.
By and large, I mean, sometimes when you do a laser cataract, yes, you get these very small cubes when you've done softening segmentation, which could be hiding behind the iris. But at least in the regular phaco, even though we chop it 6 or 8 pieces, they're usually large enough. You may sub-chop it. So I don't think them in a regular phaco hiding or losing a piece behind the iris is such a big concern.
Okay.
The one point I think which I just want to allude to, which Naren also is making, is when you're doing a vertical chop technique, that one of your either whichever way your technique is, the chopper going down and the phaco probe going up, that slight anteroposterior shift is necessary. But when you're doing a horizontal chop, there is a little more crushing force between your phaco tip and the chopper which is moving in. So instead of keeping the phaco tip right in the center, you can actually go a little more mid-peripheral, because as the distance between the area which you have to crush reduces, and again the nucleus being biconvex is a little thinner towards the mid-periphery. So it actually helps you, it makes it a little easier to initiate your crack, And then by doing a multi-level chopping, you can then propagate it towards the center. But initiating that crack becomes a challenge. And very often we end up dislodging the piece even before we initiate the crack. And that's when I think completing the chop becomes difficult.
I think one.
Madam, I can understand your concern regarding that small piece, because once you get 2 or 3 cases, then we will have that in mind always. Even in regular Phaco, non-femtos also I've got it.
That's in total hard cataracts, which is the biggest challenge. Those very, very small pieces which come.
But otherwise also I get it, because I realize that when I'm using too much of viscose and liberally pushing it inside, it can go underneath the iris, it can be in the angles and all, and it can trap these kind of things and doesn't move. And in Arcus, it disappears. So I just put viscose just under the endothelium and then put a lot of HPMC in the center so that it gets pushed up and remains where it's supposed to be. That is one thing. Second thing is, people ask me, why do I aspirate so much after trying to take out all small bits of cortex sticking there? I'm not trying to do that. I'm trying to irrigate underneath the iris in different angles. Even after placing the IOL, I know that there is no visco, but still I go underneath and turn around like this. So just creating a little turbulence inside the bag and just above the bag can bring out many of this. And look for little bumps on the iris and on the iris at the end. Sometimes it will look a little bumpy. Remember, there can be something like that. And to answer Tamilar's question, actually Naren actually showed it correctly, because we want to make a split like this. Both sides, if it moves, you need to separate only half. But if this remains center, and if you want to make this much of a cleavage, this has to move a lot towards the side. So I would always make the division here and move both hands, left and right, equally, so that you need to move only half the way. He was also actually doing like that, but your question is answered like this.
That is why we want Minu Mathani in our meetings. I exactly answered the answer which I wanted. Thank you, Dr. Minu. So let's hear from you. He is again heads the Department of Cataract Services and more at Chaitanya Group of Hospitals based at Trivandrum, and is a man with not just great surgical skill, but a huge quota of common sense. And he comes with the most beautiful tips in his talks wherever you hear him. And he is going to tell us about approach to posterior polar cataract, his pearls.
So thank you, madam. Is my video seen?
Yes.
Yeah. So this is a 4-minute clip, so I won't go beyond that. So I need to play this. Clean. What's all this? So yeah, so it's on. The thing is the femto. If you have a femto, that is the ideal way to do. I will do all posterior polar cataracts with femto delineation. So you get delineated as already shown by Shale, but then you get this cylindrical cuts, and it's like a delineation without any hydro procedure, and you can gradually go around it and aspirate it off. Once it is finished, then comes the outer epinuclear shell, which I basically use the Phaco probe and my blunt tipped 2mm chopper, which is used to go around and mechanically separate. I can show you the viscose separation in another case, and mobilize it out, and then see this. Then always take out irrigation after replacing the anterior chamber with viscoelastic free filling, because any shallowing or hard deepening can open up this kind of weak areas, and then most of the cases you can get away with it. Here is a second case with the already open posterior capsule. So Rex is very important. This is my coring technique. So this goes around the nucleus with minimal aspiration and adequate energy, and the central core is taken up. And the periphery now, I use my 2mm blunt tip chopper, go to the periphery and mobilize it gently so that all the epinucleus comes out from the equator, and towards the end, we can lift it out. Basically, it's not rotating. It is lifting out of the bag mechanically. And also while exchanging, replace with viscoelastic. And I use basically bimanual in this. When you're exchanging again, use viscose or sodium hyaluronate. And many times you may not get vitreous out. If you get vitreous, you have to do a vitrectomy. This was lucky. And you get this kind of a pillar-like opening. And I use always a 3-piece lens. And if your axis is 5mm or smaller, this is slightly larger, but it can be used to capture your axis. Here again comes a third case with a harder nucleus. So here no hydro, no rotation. First chop and second chop, and slowly extend and then take out that piece. Once that is done, go towards the left. Again using a sharp tip chopper. One more chop. Go towards the right. One more chop. So 1/3 of the nucleus is gone. No rotation. Now I change my chopper tip to the blunt tip. Go to the equator, cross chop, separate the one more piece, and now one half of the bag is free. See, now this is lifting up the nucleus. There is no rotation. It is lifting it into the free space in the center. Again, go beyond it, beyond the equator, and lift it up. And once it is in the anterior chamber, it can be completely emulsified under viscose cover. So no chamber fluctuation, very, very important. No too much of deepening. And now this is the viscose dissection, which can definitely bring out a lot of epinucleus, which is there in the periphery, assisted with my mechanical movement, and you can aspirate. Now, this is a classical posterior polar, and after taking out, you can see sometimes there are very thick plaques. Most of it can be just left and you can yag it later, but in the center, if it is too thick and too large, you can try to separate it, but most of the times it will come with the posterior capsule. So if it cannot be separated, we can also do a posterior capsule rhexis on the primary sitting also. Include this area, do it just beyond it and rotate it like your regular posterior polar, posterior capsular rhexis, and complete the posterior capsule rhexis. So the plaque is also gone. You mostly do not get vitreous disturbance if you have a little sodium hyaluronate on top. I place a 3-piece lens into the sulcus. And to capture it properly, I would like to evacuate the bag relatively. So I go in with minimal aspiration flow rate and aspirate the sodium hyaluronate. I use only sodium hyaluronate, don't use HPMC. But later on, if you have a slight bit of doubt that you are aspirating vitreous, please, I'd use a vitreous cutter and cut the vitreous. And now you can see that this is a adequate capsular rhexis where I can capture the optic and the central rhexis margin. Thank you very much. 4 minutes. I had to stop 4 minutes. Thank you.
Yes, yes, amazing talk. So Tamil, take his questions.
Sir, have you tried oval rhexis in PPC, sir? Or
I'm sorry. Your question was totally broken. I couldn't hear. Voice was broken. Once more.
Oval rhexis, sir.
Oval rhexis. I've heard. I've seen people do oval rhexis, is it not? Yeah,
yes.
yeah.
Yes.
I have seen people doing oval rhexis, and there are some advantages that you can use that extra area to do all those. But then towards the end, if you want to capture an optic properly, it should be a round rhexis and a smaller rhexis. So I will tend to do a round rhexis rather than an oval rhexis, although it has some advantages like using the extended area for more chopping and taking it out and all.
Oval rhexis, you should ask Kiranjit, Dr. Kiranjit only. He is the man who initiated the oval rhexis. So how could he not be asked? So tell us about oval rhexis very briefly.
So oval rhexis will give you advantage of both the small and the large rhexis. Large rhexis for taking out the nuclear segments out, and if in the end you get a PCR and you are not able to put the lens in the capsular bag, you can optic capture a 3-piece lens in the sulcus. So it has advantages of both small and large rhexis.
I think Tamil, you should tell about your experience with the ASOCT in posterior polar cataracts.
Yeah, that's what I mean. I missed that. Nowadays, I'm doing in every case, and I was stunned one day to see Dr. Ramurthy easily rotating one nucleus in a live surgery in a posterior polar cataract, and nothing happened. And he totally believed the anterior segment OCT. And nowadays, I also started believing anterior segment OCTs. Actually, anterior segment OCTs are very good guides. Maybe sometimes, but then there are some gray areas, but most of the times they are very good things. Tamil, please, you please highlight this.
Tamil?
Tamil just went off.
Yeah.
She got maybe disconnected.
No. She's a smart guy.
She got disconnected maybe.
Disconnected. Yeah. So we'll come back to Tamil's question. Let's take Tamil. Are you
Yeah,
back?
she's back. Yeah.
Tamil?
Yes, ma'am. I got disconnected.
Yeah.
Yes, sir. Actually, ASOCT has a high negative predictive value. So it means if the PC is intact and traceable beyond the opacity, it means that the likelihood of PCR is very less. So we started doing, and we all know that if you're going to do a hydrodelineation, taking out the epinucleus sheet is going to be challenging and more chance of PC dehiscence. So in cases where the PC was traceable, and we did a gentle hydrodissection and nuclear rotation, and we proceeded with routine Phaco parameters. And we also took precautions like maintaining the AC stability, and we do not go and do a PC polishing with a aspiration cannula, but we did a hydro polishing. And the second group where the PC was not traceable behind the opacity, we did the routine hydrodelineation, and we didn't rotate the nucleus, and we followed all the precautions. And only in the initial one case, we had a PC dehiscence following a hydrodissection, and most of the cases, like we had around 56 eyes and 55 eyes, it was like a routine phaco with gentle hydrodissection. And we could even implant a premium lenses in these cases. So ASOCT is done routinely, and based on that, we decide whether we can go ahead with the hydrodissection or not.
Thanks, Samul. We have one more speaker who has also joined in. So Dr. Rohit, I'm going to take Dr. Anurag Mishra first and then Dr. Rohit. And we really have to thank Dr. Rohit because he actually, I emotionally blackmailed him for not being in this meeting. And he actually readied his 10 minutes talk into 4 minutes. So we will hear him. So all of you, please stay connected for him. We shall now go on to Dr. Anurag Mishra, who is a great surgeon par excellence and practices at Radha Raman Hospital in Telugu Bazaar, Cuttack. And he's going to talk to us about aligning the toric and multifocal IOLs for perfect outcomes. Dr. Anurag Mishra is an amazing
Admin, please
surgeon we
give
all
me the...
know. Huh?
No, I said, ma'am, admin has to give me the permission to share my screen. I'm not able to share my screen.
Oh my
The
God.
share button is dead.
Wait, well then, what is happening today?
Yeah. I think it's...
Yes. No, some permission is asking. Dr. Minu, your presentation was very nice.
Thank you.
Thanks a lot, Dr. Rohit.
Thank you. Hi, good evening, ma'am.
Yes. We missed you. There were a lot of
Sorry,
input
but my presentation is, I would not be able to present, but I'll be part of the, webinar.
Yeah,
So
sure.
because there's an issue with that. So because of which I couldn't,
Oh, that's okay. You have been with, we are there. Let's discuss Anurag Mishra and his talk threadbare.
Thank you so much, Chitra ma'am, Team Eye Foundation. Good evening, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. I'll start my talk with a small rigmarole, which involved a patient. And he came to me after a toric IOL implant. And he had no particular complaint and he had just come to me just like that. It's like some tearing, watering, some itching, some sort of trivial complaint was there. I put him under the refraction board first. It showed me that the patient, of course, as I said, had no visual complaint. The right eye was the one which was pseudophakic. The phoropter screen showed that he accepted a 0.25 cylinder along 165 degrees axis. And the vision was 6 parts even uncorrected. So 0.25 just made it a little clearer. But when I dilated the patient, I saw the toric IOL being malaligned or placed at 7 degrees off axis. I was curious and I subjected this patient to eye trace. And this is what I found. The top left-hand picture will show you the DLI scores when there has been no glass correction. As you can see, the glass sign has been, the spectacle sign has been put a cross on. Although the internal plane shows a DLI value of perfect 10, you can see the distortion that's there. Down below, when the glass correction is being placed, the distortion is gone completely. I've intentionally not hidden the name of the patient right on top, right-hand side corner, as you can see, so that you get to know that it's the same patient I'm talking about and not doctored the pictures at all. If you go to the MTF screen, same patient, the MTF value, look at that. It is crossing the critical square. The value at 10 cycles per degree is 0.137 in the corneal plane and 0.170 in the internal plane. But when we are correcting it with glasses, the MTF scores also increase. What it means is, even with a 0.25 cylindrical residual, we say that 10 degrees off axis alignment is what is important or what is significant. But even below that, it can cause distortion of the imagery, even if it doesn't reduce vision per se. So here is what is important. We have to align the toric IOLs exactly along the desired axis or the axis that has been told to us by the IOL calculator. How do we do that? We ensure a proper alignment first, and then we ensure that there's negligible post-implantation rotation. How do I ensure that it is a proper alignment? The first thing to do is to register the eye. And I use an image guidance almost exclusively. Why I'm speaking of image guidance is because people think that if you manually mark, you're likely to go wrong. But the moment you install an image guidance machine in a setup, you're completely foolproof and you're likely to hit the target bang on 100% of the time. Doesn't happen always. Look at this screen now. This is a perfect eye which is being registered under the microscope, and the registration is failing. This can happen even if you have selected the right patient and the right data has come in, the registration can fail due to several reasons. What you do then is you just align the axis negatively by 1 or positively by 1. This gives a signal to the machine that you're trying to override its automated registration system, and it goes to the manual mode and then registers the eye. This is just one trick. This can happen to everybody. I minimize the use of viscoelastic. Not only do I hydroimplant all my IOLs, but the other tip I use is the IOL is brought right next to the tip before it is implanted. So the IOL is right next to the tip of the cartridge, so that very minimal viscoelastic is left even in the cartridge beak. The moment you lift the leave the IOL inside, the viscoelastic that is there, which is minimal in quantity as it is, gets washed off with the fluid current. However, when I use IOLs which are not exactly truly hydrophobic, meaning the water content is slightly more than 1 to 2%, as in this IOL, this tends to be sticky. These IOL surfaces tend to be sticky and they adhere to the viscoelastic more. So what I do is, after implanting them inside the bag, I just rotate them clockwise and counterclockwise a few times before aligning them along the axis so that all the viscoelastics are washed off. I don't need to use aspiration per se, just rotate it a few times so that the viscoelastics get washed off. When we align the toric IOL using an image guidance, there are 3 things which we should notice or we should ensure. 3 messages that come in the image guidance. One is a parabola that comes on the left-hand side, as you can see here, and there's a ball that is traveling throughout the length. This parabola tells us that there is 18 degrees of cyclorotation being compensated for. That's what the image guidance can do. The cyclorotation is more than that, the ball will disappear and you know that you're not aligning it properly. Number 2, the IOL has to completely unfold before you align it. If it stays if it stays scaphoid, then the alignment is not proper. Third, down below, there is a message called tracking OK. The other message that sometimes comes is center the eye. We tend to miss that. We have to ensure that the message comes in is tracking OK. Only then you know that you are along perfect axis. Let me give you an example. Here is a case where the alignment axis is 173 degrees and the ball is in the parabola and the message down below is tracking OK. I try to align it. By aligning, in the process of aligning it, what I miss is the ball is actually attempting to go out of the margin. It's gone out, and look at the axis. It's shifted, it's changed, but that's not the proper axis. So I get bewildered. I miss the point that the parabola is not having the ball right now. I rotate it back, which is actually not the right axis. Then I remove the 2 instruments from the eye. The eye comes back to its original position, and we get to see that the axis is shifted back. Now the ball has come back to the parabola. So it is so very important to see whether the ball is there in the parabola, in the parabolic premises or not. Because when we introduce the irrigation cannula, accidentally, inadvertently, we actually also induce some amount of cyclotorsion without it ever coming to our notice. All our focus is on the IOL. Here is a case wherein the axis, despite of everything happened correctly, it is 178 degrees. My incision is 180, but the axis is shown elsewhere. So what I do is I switch off the image guidance there, and I go back to my axis marking, which was along 180 degrees. Now it shows that I'm bang on. So this comes with experience. Even with all the help you get from the machinery and the ecosystem, sometimes you have to get back to your experience to know whether you have aligned it properly or not. Irrespective of, so this is about how to properly align it. This is about forming the AC after it has been aligned properly. Now we are we have implanted an IOL that has the track record of the best post-operative rotation of stability. Look at the IOL rotating when you over-enthusiastically inflate the AC. It gives us a strong message that herein the pupil is well dilated, so you could see the marks and you could see it rotate. But if the pupil would have been any smaller, then it would have been hidden. So it is very important for us to realize that the AC should be formed just to make the globe turgid and not overinflated at all. When we handle small pupils, the trick is to rotate the IOL to the proposed axis of alignment, close to it. And with experience, you know where the axis is. Then you rotate it slightly so that the mark is seen. Repeatedly retract the pupil to see whether the mark is along the axis. You can use the same dialer, Sinsky, or you can also see a Y-shaped hook, which hooks the pupillary margin and retracts it so that you get to know exactly where the IOL marks are before leaving the IOL. This is one special situation, the small pupil toric alignment. And the other special situation is this. This is a posterior polar cataract, and you can see the big PCR that's happened. Luckily, I had enough capsule to support the haptics. However, I must do a reverse optic capture here. So the reverse optic capture is something that you do. But after the reverse optic capture is done, the irrigation cannula is something I do not withdraw instantaneously. I stay there with the irrigation cannula on. The ball is still there in the parabola. The message is centered, tracking OK. And while the irrigation is still being pumped, the AC is formed through all the other ports that are available. This is something I do because once the reverse capturing the optic or even capturing the optic in a single piece IOL is not very easy. So I just make sure that the AC does not fluctuate, it doesn't depress, it doesn't shallow or doesn't deepen quickly, so that the irrigation cannula maintains the AC while the other ports are sealed. That's all I could manage in this edition. I think there are many other things to go, but I intentionally just skipped it in the interest of time. Thank you so much for the opportunity, ma'am, once again.
That was a wonderful talk. Every word said was brilliant, and you're one of your best talks on drugs. So damn good. So just maybe one question, Tamil, you could take before we all say bye-bye for after a wonderful evening.
Yes, ma'am. Like, what are the tips on manual marking if you're going to do, Dr. Anurag?
Yeah, I mean, it's very traditional teaching, Tamil. You have to dry the cornea, you have to mark it in front of a slit lamp or anywhere when the patient is seated, so that there's no natural cyclorotation happening. It should be as thin as possible. You take the patient to the OT, ask him to lie down, reinforce the marking again as thin as possible. But in my experience, no manual marking, actually, it's not worked in my hands properly. No manual marking I have been able to produce, which is not fudged and which is as thin as the image guidance. So sometimes it is wider than is desired. Sometimes the marks on the proximal and the distal parts are not along the same line. So one of them is aligned, the other is not. So the parallax is more likely to happen. So these are the things. But talking about tips, yeah, they should be as thin as possible, bang on opposite. And when you mark it on the table, the Purkinje image should be right at the center of the hole when you mark the alignment axis.
Dr. Rohit, would you want a question to ask a question?
Yeah, Dr. Anurag.
Yes, sir. Good
The
evening.
DLI score was, how do you explain that with minus 0.25?
You will be surprised. I mean, even I was surprised. I must say, sir, that the DLI score, objectively traced on the eye trace, sometimes actually overestimates things. I do agree to that. But what it does tell us is there is an image distortion. There is an image which is not exactly clear. There is a defocus that's happening at the imagery plane. It does tell us that. Because
Could it be because of some posterior capsular opacification?
So then it will not be clearer with the 0.25 cylinder being in place, sir. If it is internal,
Absolutely.
then it will not go away with the spectacle correction.
Absolutely. So very difficult to explain because with with 7-degree rotation, it should not have been only minus 0.25.
No, it depends on the toric trim, sir. How much of
what I'm trying to say is So misalignment would have caused, plus minus sort of situation, not.
Yes. Yes. So for this patient to have a spherical equivalence as 0, you have to put 0 plus 0.12 as a sphere,
Yeah.
which is not available in the phoropter machinery that I use from Topcon. So it starts with a 0.25. So that's the reason maybe I couldn't place it. I tried to place a 0.25 if the patient didn't accept. Perhaps a 0.12 would have been accepted by the patient. But yeah, I mean, yes, sir.
Sorry, go ahead.
No, I was saying that sometimes, even if it is below 7 degrees, the measurable toricity that is there is, I think we started from 0.25. What I wanted to impress upon is, even if it is less than 0.25, which is not measurable, which we do not place as a correcting lens in front of the trial frame or in front of the phoropter, the image distortion could be there. This is completely, this has opened a new dimension to me. I'm trying to study more on this. This is just a chance discovery that I made, and I'm trying to look more into it. But yeah, I mean, this has opened a new thing to me.
Absolutely.
Very nice presentation, Anurag. And objectively, you showed that 0.25, the difference it makes. But practically, we don't really see that. I at least have quite a few of my toric patients who have a 0.25 cylinder left over. Optometrist notices it, but then patient is not complaining and I don't do anything about it. My tolerance for rotating lenses is very low. If there is a complaint, the spherical equivalent is nearly 0, I go ahead and rotate. But then having said that, there are quite a few patients with 0.25 cylinder or even occasional 0.5 cylinder who had initially started with the 3.5 cylinder, and the patient is not complaining, I leave them alone. Frankly, I don't put them on a eye trace and see what is their DLI score. But then I don't know whether they would be complaining a lot more if it caused such a significant deterioration.
No, sir, this patient also was not complaining of anything. As I said at the beginning, this patient was not complaining of anything with regards to vision. He had just come for some watering issue or something of that sort, if I remember. So, but when we placed the 0.25 cylinder and asked him to look at it meticulously, reduce the contrast on our charts, tried to look more into it, more detailed into it. Of course, we didn't overdo it because then the patient will think that there's something wrong happened to with regards to the placement of the IOL. But we did see a difference. The patient was able to experience a slight improvement in the vision quality when we were placing the 0.25 cylinder. So it needs to be looked at. But the point here is we should always ensure that it is aligned along the exact desired axis as has been depicted by the IL planner.
Perfect.
So I think we need to conclude. I'm sure all
Madam,
of
one point he was telling about the thinness of the marking. We can
Yes.
use a very small 27 gauge needle to make a thin strip, so that will be a very thin mark. And also nowadays I've started loading the Salcon lenses under saline, so no visco into the cartridge also. So many lenses can be loaded under saline, and so no visco at all to go underneath the IOL also. You don't have to.
The haptics don't get stuck?
No. Saline haptic, no haptic, you don't understand.
Has a silicone coating on the underneath, on the inner side of the cartridge, ma'am. So the passage becomes little, I mean, way easier than what we can expect from a typical hydrophobic IOL. But it is, I mean, sir is obviously far more
No,
experienced.
for years, I am using it in saline only, all Alcon lenses. It just goes smooth.
No, just so that anyone listening doesn't go away with the impression that you need a digital marking device to start toric lenses.
Absolutely.
Well, something like immersion A scan and optical biometer. It's great to have an optical biometer, but that does not mean that if you don't have one, you can't do torics or multifocals with immersion A scan. Similarly, there are several studies which have shown, even when we transited on to digital marking, which was almost 10 years back, where when you compare patients getting a manual marking done and digital marking done, the results are almost comparable, at least when the surgeon is very adept at doing the digital manual marking. Of course, it's much easier, and I completely rely on my digital marking device. But just in case you do not have it, does not mean that you should not be implanting toric and toric lenses.
True, sir.
Thank you. Thank you so much, one and all of you, for giving this wonderful meaning to this webinar. I mean, the way we conceptualized it, all of you made us realize that with the best of speakers like you, it cannot but be super best. Thank you so much. Thank you.
Claps for you, ma'am.
Thank you,
Fantastic.
madam. Thank you. Thank you very much.
Thank you,
ma'am. Thank you, sir.
Thank you, sir.
Thanks,
Thank you.
Rishi. Thanks, Rish. Thanks, Naren. Meenu,
Thank you. Thank you.
Anurag, and everybody.
Thank you, ma'am. Thank you so much.
Dr. Rohit, thanks a lot. Dr. Kiranjit, thanks a lot.
Thank you, ma'am. And sorry
Thank you.
yeah, I couldn't,
It was
be
a
part of-
wonderful meeting, actually.
Yeah.
Anyway, we missed it. Thank you. Thank you.
Bye.
Good night,
Nice. See you. Good night. Good night.